to call liver failure nutritional liver failure. It was induced because what does that liver do? It metabolizes all of your food sources. So these patients really are nutritionally very poorly. They just have poor nutritional abilities. They can't metabolize all of these food sources, so they're just really cachectic. And that's the last thing these patients need when they're this critically ill. It's really my favorite organ. And Dr. Stoltz, will this work here with me pushing it forward or not? Will this work or not? No? Huh? No, I don't know. Check it out. But it does over 400 functions. So the liver is extremely what? Busy. It's very complex. Very complex. I respect the heart. The heart is really a machine. It's an engine. It's really not too hard to demystify what its functions are. But of course, it's essential for life. The liver is very powerful with 400 functions. So you can imagine if you start having failure. Thank you. We're going to see a lot of interesting findings, and we're going to have a challenge taking care of these patients. All right. I will tell you that we probably have the best hepatology team in the United States here in San Antonio. And I'll tell you why. We have great surgeons from Cleveland Clinic. We have UCLA people here now because, unfortunately, our region of the United States has the highest levels of NASH and NALS. And you learned all about those in chronic liver failure. So, and also, we are number 2 in the United States in living liver donation. It's us at University Hospital, number 2 in the United States. Is that powerful? Absolutely. So we are very well known in the country for caring for patients with decompensated liver failure. It's exciting that we have that. All right, so let's get going. You know your objectives. They're there, they're listed. If a slide says chronic, I'm not going to test you on that content, just kind of giving you a perspective how this evolves from a chronic to an acute situation. We won't talk much about that. But one other thing, too, that I need you to remember, you have a liver case study that you're going to do. It will open at the end of this lecture. Okay? That is a patient that I took care of several years ago here in University Hospital. And so it's his life, it's his story that you're going to be reading. And some things have been altered. Of course, we need to do that when we're putting things into a case study scenario. He actually was younger than the story the case study says. But in that case scenario that you're going to read and you're going to look at labs and then you're going to answer questions too, I'm not going to test you on the liver transplant aspect of liver failure, but you're going to do the case study. I will want you to know the medications that I will be testing you or challenging you on. You know them already under this liver case study. If you have any questions about it, just send me an email. Okay? No problem at all. So that will help hopefully reinforce this for you. It was really exciting to take care of this young man, actually. Okay. All right. So it's huge. It's right here in that upper. And you thought, oh, Lawrence, why do we have to review this? Let me tell you something. If you know anatomy, physiology, just that alone, and then patho, you know how to take care of these patients. Trust me. You know what you need to do. And you're going to be there really intervening perfectly for these patients. The interesting thing is that a tertiary setting, how much of the patient's hospitalization, how much time is the provider there? Of the 100% of the time they're hospitalized, how much percentage of that 100% are providers there? And I mean by providers, even, the PAs and the nurse practitioners. 100%. Who is there? You are there, right? You're seeing signs of AKI. You're seeing signs of sepsis unfolding. You're catching these things. You're seeing what? Their assessment findings change. This is up to you guys. It's in your hands to do the right thing, right? Absolutely. You're there 90% of the time. You're trending them. You know them. You're trending them assessment. You're trending them with labs. You're trending them with the medications and seeing, are they responding as I want them to? So it's really in your hands with all of these patients that we care for in adult too. Because they're what? They're in a tertiary setting. They're not in clinics, which is sick. So big organ, right upper quadrant, and it conforms to that concave outline of what? The diaphragm. But interestingly, it is connected actually to the diaphragm through the thousand ligament, so it moves. And if you breathe, it moves. One interesting thing about this I want to point out is it's covered with that listen capsule, which is a tough connective tissue coating. When we talk about pancreatitis, the last hour is very different. And there's very interesting things that happen because of that. So it has this tight listen capsule that can cause some interesting problems with liver failure. Okay? It's huge. 3 to 4 pounds is enormous. And truly it is this size. And it's enormous. Yeah. And organ function. Oh my gosh. Incredible organ. I love it. I fell in love with nursing school actually. Yeah, I did. Many years ago. I've been for 47.5 years. And I am retiring in December. Good, right? After all these years. So the functional unit of that liver is what your lobule is. Okay, so you've got tons of them. 50 or 100,000. You have a lot. Okay. But within that, and we're going to look at this architecture. I want to demystify all this. I don't want you going in and memorize it. I want you to slide with these slides and be like, I got it. I know what to do. I get it, right? Because your questions are what the application is. Oh, that's what we want you to take theory and apply it. And I also want you to do that clinical. Okay, we have hepatocytes. They're the workhorses of the liver, right? They perform most of these organ functions initially. Yes, initially. I'll show you something in a minute. I'm going to talk to you a minute about the sinusoid, the structure of this lobule. The interesting thing is the liver receives 25% of your cardiac output per minute. Is that a lot of blood? It's enormous. It's enormous. But let me ask you one question. What if I start having fibrotic changes from cirrhotic issues? What if I start having edematous changes from the liver being destroyed? What if I start having necrosis? Healthy liver, 3 pounds, lovely, nice, cirrhotic liver. Can that cardiac output get into a cirrhotic liver? Well, it can't. No, and that's what we're going to start seeing from sinus symptoms to manage. This is really, truly what it is, right? Yeah. All right. Cover cells, so you know what? You get a rich blood supply from your coral vein, which is turning all of the blood from the mesenteric vein, which is rich in nutrition, but it's rich in bacteria too. The liver, literally through the cover cells, they phosphate this blood and they make it clean and nice. And so let's prevent infections. Infections are happening with this, they are prone to a lot of infections. 5 canoniculi, you know, I drink, we urinate, we eat, we have stool. The hepatocytes work and they produce bile. And then we'll talk about space and juice in just a second. This is the kicker right here. This is a beautiful picture of that lobule, isn't it? But tell me one word, you looked at this. This is so important to think about this picture. What would be one word you would describe this picture as? Just one word. It is what? Tell me. Is it the architecture of it very, very specific? It's triangular. Is it extremely organized? I mean, isn't it? And you've got 400 functions working in there. And so here, let's say this here is my lobule, and here's my sinusoid. 25% of cardiac output's flushing through here to interact with the cover cells, to interact with the hepatocytes, to make bile, to make a third of your lymphatic reduction of lymph in your thoracic duct. It produces a third of that to a half. What would you think if I start having, and just here's my blood flow. Let me work with you. I'm having swelling. I'm having a lot of necrotic changes with this opening what? Narrowing. Can it do these 400 functions? Truly, that's the bottom line of this. The architecture of this structure is perfect. You start messing with it, you'll decompensate liver failure, and of course you're going to see all these exaggerated findings. Yeah.
Yes, can you please speak into the mic?
Yes, sorry. Remind me. I'm not offended at all. I'm glad you're telling me. But if you were to follow this just quickly, sinusoids, 25%. Interfaces with the hepatocytes, they make what? Bile. They make excessive lymph. Excessive fluid goes in. This is just so organized. But we really mess it up when we get into liver failure, unfortunately. That's all. It's really what you need to know. Told you already, a lot of blood. 25% oxygenated blood from the hepatic artery. The rest of it you get from your portal vein. So one of the decompensated problems is they get what? Portal vein hypertension. Yes, of course it is. Yeah, this makes a lot of sense. We don't have to memorize 5,000 PowerPoint slides. We can do this. Y'all are smart. Okay. I've already told you about the portal vein, and we'll talk a little bit in a minute about portal vein hypertension, portal hypertension, hepatic artery, great. Hepatic vein, it just exits this rich blood supply and dumps it into the inferior vena cava and then ultimately to what? The right side of the heart. One thing you're going to see in a minute that's a problem with acute liver failure is when a patient develops right-sided heart failure. How does that correlate to liver failure? Why? And if I had our little statue that we use downstairs in the CSI, you would see the liver right here, and right next to it is the heart. So that right side of the heart starts losing its positive inotropic ability to contract. What's happening with all that preload? Can it move forward and be oxygenated in the pulmonary arteries and then go to the left side of the heart? Can it? No, that right side of the heart is failing. So where does that blood go? It just stays there in the liver. And so what happens? They go into liver failure. Oh, that's truly what happens. My father had he had restricted cardiomyopathy episode, and he developed ascites and liver failure from the right side of heart failure. So you can see why this thing occurs. Okay, good job. Biosynthesis, absolutely byproduct of the hepatocyte function, and it produces a lot, up to a liter a day, and it's mainly composed of bile salts, bilirubin, some electrolytes. Doesn't alter your electrolyte, your BNP at all. That's okay. But it's really essential. We need that bile for the emulsification of fats and fat-soluble vitamins, right? Absolutely. So what do you think about if I start having problems with even bile production or getting it into the duodenum, and I'm unable to emulsify and utilize and absorb these fat-soluble vitamins? What do you think you're going to start seeing? What would be a big one, and what do you see in these patients? They bleed easily, right? What are those fat-soluble vitamins? A, D, E, and K, right? So these patients bleed easily from liver failure. They just most certainly do. And part of that's attributed to the bile issue. And then we can just look at this. And so the liver, again, it has all the small bile canaliculi, and they come together into the right and left hepatic ducts, and then it merges into it leads into the cystic ducts. We store that in the gallbladder bile right when we need it, right? And then it goes to the common bile duct. One thing I want to point out to you, because we're going to do liver next, is this is that liver, right? That common bile duct literally joins with your main pancreatic duct. Do you think I can start to have pancreatic issues with patients who have problems with the common bile duct? It's just anatomically because of its location. Absolutely. Okay, metabolism. These patients are nutritionally in the toilet. They are very cachectic, as I told you. They may have tremendous ascites in their abdomen and lower extremity edema, but they really are nutritionally terrible. It's really bad because they can't process carbohydrate. They have a problem processing proteins. The big issue that I want to point out with protein, just because we're taking care of acutely ill patients, is this. Remember that in the liver, it deaminates what? Your amino acids. But one of the byproducts of that production of energy is what? Ammonia production. But then in a healthy liver, that ammonia is converted to urea and then be eliminated through our kidneys. The problem with these patients is, are they able to convert ammonia to urea? No. So they have what? High ammonia levels. And we'll talk about how that affects them. Yes, I just wish, I missed being in clinical this time because University Hospital is just, it unfolds this content like every day. It's just beautifully seen before your eyes. And so many liver failure patients, I mean, it's really sad. We talked about the fat-soluble vitamins, A, D, and K, and so we're going to see implications truly with K in blood clotting, right? And what? We have about, I think, 7 of our clotting factors that are made where? In the liver. So the liver starts folding even in blood clotting factors and abilities get altered. These patients bleed easily. And actually how they die is nutritionally they are very, very poor and they bleed to death and they get septic. That's truly what pretty much bites them. Okay. Bilirubin. So we know when you do bilirubin, you can do a total bili, you can do it indirect, you can do it direct. These patients have the inability to get rid of bilirubin. So that starts building, and we talked about that in chronic, about the pancreatitis and the other issues. We'll talk about in a minute. Now here's another interesting thing too. What about drugs? What about hormones? What about toxic substances? Many of the drugs, when you were with Dr. Karbowski, where did these ultimately get metabolized? The liver, right. So they're in liver failure. Can we give them normal amounts of drugs? Absolutely no. We've got to be so careful because they can't metabolize them, so they can get really high trough levels if we're giving them vancomycin, if we don't watch the amount we're using because of their liver failure. Yes. Now, an interesting thing that I've listed here is ADH, antidiuretic hormone, aldosterone hormone. What do both of those hormones do? They hold on to water. Exactly. Okay, but when I'm in liver failure, these levels will rise, okay? So it means I'm going to hold on to what? More water. I got a big problem though, because where is albumin only made? In the liver. And what's the role of albumin? Positive oncotic pressure. So I'm holding on to all this daggone fluid from hormones that I can't degrade anymore because my liver's folding. But I don't have a normal level of albumin. We like them to be what, 3.5 to 5. Often you're going to see, like at university in the VA, 1.8, 2. So they third space, right? Yeah, they most certainly do. Well, we'll be looking at problems with estrogen, testosterone. They start building the levels of these hormones too, and I'll show you the sequela of what you'll see based on that. And you're like, well, I don't care. Yes, you do. You are going, yes, you do care. You want to be able to identify these signs in your patient. You want to have credibility with teaching them and talking to them and helping them, right? You really do, absolutely. Kupffer cells, they get easily infected. There's no doubt about it. Blood clotting components, they bleed to death, right? And then there's that activation of growth hormone for healing, right? Growth, absolutely. But you know what, in those sinusoids that I just showed you, we can store upwards to about 400 or 500 milliliters of blood. And when my body senses that it's low on volume, it will literally release this stored blood and help raise your preload, your effective circulating volume. It stores sugars, of course, it stores fats, and it stores a lot of your vitamins. You don't even know how many years worth. I think in A, it's what, about 1 or 2 years storage. Anyway, it's interesting, right? It's just fascinating. So just in summary, we produce a lot of bile. We know it's necessary for fat emulsification of fats and also to absorb fat-soluble vitamins. Great. It stores essential nutrients, stores energy for further usage. It metabolizes all of your food sources. These patients really are not nutritionally sound, and then that leads to even more problems. They just can't, they easily get infected. They just don't prosper at all. They just not. It makes the protein. Protein is what? Essential for life. We know the criticality of albumin only made by the liver, and those levels drop dramatically. Stores, filters blood, help us not get infected, and then clotting. So that's the bottom line. Now let's look at the labs that you will be responsible for, because they'll order, okay, you know what, I want you to do a BMP. You're going to do it every 12 hours. You're like, check, I did it, and I put it on Epic, my EMR. But that's great, but what do I need you to be doing? I need you to be trending and saying, wow, look at this, look what's going on. So bilirubin, of course, is going to do what? It's going to become elevated in these patients. We know that's going to happen. We know how they look when that occurs, right? We'll see some pictures in a minute. Now, liver enzymes, AST and ALT and LDH, they absolutely go up. They do. They'll become elevated. But I want to point out on all of the labs that I've identified on here, really what's going to tell Rice about the functional ability of this liver in my acutely ill patient is bilirubin, ammonia, and the INR. There's tons of hepatocytes, right? Millions of hepatocytes. When they lyse, they let go of what? All these enzymes. So yes, they go up. Yes, I'll look at them. Do they really tell me in the long run about the functionality? Not really. Okay, but consistently high bili, 3 times the norm, consistently elevated ammonia levels, and consistently high INR, saying I can't do clotting of your blood anymore. That will tell me this liver is in serious trouble. Under urinary bilirubin will go up. The only thing I want to point out about this is, have any of you noticed what their urine looks like when they're really at this critical state? It's very what? It looks like Coca-Cola. And it might have even froth on the top of it. But truly, it's this bilirubin that's causing that coloration of their urine. So it's a small amount, but it's very like Coca-Cola. All right. Are we okay, guys? Good. You guys are doing great. Diagnostic studies. And here's the thing. Yeah, we're going to do it. We can anticipate. And boards, they may even ask, what kind of thing would you be anticipating orders for? And you're like, hey, I'm the nurse. Why is that on me? But 217.11, which is what the heartbeat of the Nurse Practice Act. And I know you studied it first this semester in concepts. It says in there, when they order, whatever they order, you better be sure what? It's appropriate for that patient, right? If there's any hint that you think it's not, it's on you to say something, right? Absolutely it is. So yeah, you do need to know about all of this. Now, when we do an ERCP, now I'll tell you what, these patients are critically ill. If they're on a ventilator and having a Swan-Ganz and maybe on CRRT, they're not going to be able to endure an ERCP, because with an ERCP, they have to lay on their stomach. They literally have to be prone. But the issue is this. Whenever a procedure is done to your patient and you know what it is and you can explain it to the family, answer questions for them, that's all great, and you can be sure the orders are great from the physicians. It's that post-care that's on you, right? Because there's things that can always go awry. So you've got to understand that. So let's talk about that. Of course, we need a consent form, absolutely. They're going to have contrast dye. So have they had a prior allergy to it? Hopefully your EMR will track that for you. It will pick up on that so that you don't give them something where they've had a prior allergy to it. But we know that if they do get this, these patients could have what? They could go into AKI, right? With that contrast dye. You know from that lecture from Dr. Richardson. They can easily go into kidney injury just from this dye alone. Alrighty, so you'll watch for that. You'll be watching for that. Any other allergies? They're NPO. They may give them a little bit of glucagon prior. This is the hardest procedure for any GI doctor to do. Okay, so they're going, what is it? It's an endoscopic retrograde cholangiopancreatitis. So as the little picture shows, of course I'm doing it endoscopically. I'm going to go into the duodenum, and when I'm in the duodenum, I'm going to locate that little duct of Wirsum, that little bitty duct of Odie, and I'm going to put that catheter in there. Sometimes that glucagon will relax that little duct of Odie, that sphincter of Odie, because I've got to get in here. Now, I told you, here is the common bile duct, here's the main pancreatic duct. They join. They literally join. It's called the ampulla vader, right? Okay. Vader handles, it looks kind of like a handle vessel. If I go up here, it's hard to do this procedure. It's not easy. I could literally, by going up there, and if there's an obstruction, a gallstone, whatever it may be, I can literally, when the pancreas senses that pressure, that catheter, it can start releasing those exogenous enzymes and start what? Pancreatitis. And you're like, well, Rise, I don't care, that's the last hour. But you do want to care, because I have to be watching for what? Signs of pancreatitis in these patients. It can happen, absolutely. And you're there 90% of the time. So you've got to take good care of me and my husband. I'm counting on you. All right. So post, of course, watch their vital signs, right? We've given them a little bit of some fentanyl. We've given them a benzodiazepine. In liver failures, they do better with liverine. They don't do as well with Versed, midazolam, because it's harder for the liver to process it. But we'll be sure, and we give them a little atropine. So let's just be sure the gag reflexes return. Do they have any urinary retention issues? Any respiratory depression from what the benzos and the fentanyl? We want to really be watching them. But here you go. Signs of pancreatitis. Be watching for that. Be watching for their amylase and lipase to start elevating. Because it happens. You're just going to see it. You not only see it on an outpatient basis, but you see it in a hospital setting too. They did nothing wrong. It's just the pancreas responding to that pressure of the catheter. That's it, right? And hey, could we accidentally perforate that common bile duct? Could we perforate the duodenum? Of course we can. It's not that we're not good practitioners. It's just life. The body is very complex. So then you would watch for those signs of peritonitis. Okay, good. Questions about an ERCP? Okay, so it's on you. You have to be watching them during the procedure and certainly after. It's on you to be watching them. So we can do a percutaneous transhepatic cholangiography, cholangiopathic, where we're gonna take a little section of the liver, and we can do it several ways. We can do it by a needle stick. We're down in IR, and we can do a needle stick. We can go and do it via an endoscopic approach too. There's different ways to do it, but we're just looking for biliary tract issues. That's truly what we're looking for. But once again, since I may be doing a blind stick, or even if I'm doing it endoscopically, they could do what? They can develop peritonitis, absolutely. They can start hemorrhaging. You can start seeing signs of infection. So that's your job. They're paying you, they're trusting you to do the right thing, that you will be watching that patient carefully to watch for problems after these procedures, right? It's on you. And it truly is on you. Ultrasonography, absolutely, ultrasound or CAT scans will be done. Now, we do a fibroscan a lot at University Hospital, and really what this does is it's non-invasive, which is lovely. And I'm just going to see how much fibrotic changes does this liver have. So that's really a preferred approach, is the fibroscan to use today. Your book mentions it just as a little bit, so you'll be seeing that. All right. Now, a liver biopsy. Who has seen a liver biopsy? Has anyone seen it? Whether an IR, or they used to sometimes do it at the bedside, not so much anymore. Okay, you're like, who cares? Takes a second, but all you need to do is have one go in the toilet for you, and then you will care about a liver biopsy. We're really not doing them as often because of the complications that can occur, but we do. We still do them. So of course you need blood of consent. If these patients have an extended INR over 1.5, they can't do this. They can't do a liver biopsy. They're going to bleed out on you. We go ahead and also type and cross them, just in case they do bleed, in case complications occur. We're going to type and cross and be ready to give blood if necessary. They are NPO, absolutely. And of course, we're going to sedate them with fentanyl and a benzodiazepine. Now, during the procedure, this is where boards, remember boards is what? Application, right? They're going to ask you, so tell me what kind of a position would you have this patient in with a liver biopsy? So they're supine. You're going to have the right hand above their head like this. And you're going to help them relax. You've already given them the medications for them to relax. And then what, if they can work with you, you have them take a deep breath and hold, okay? So they hold, they take a deep breath, they exhale and they hold, and then bam. That little needle is tiny. It's tiny when we do a biopsy, a percutaneous stick. So you can imagine how I could develop what? I could develop peritonitis, I could develop bleeding. Absolutely, that liver is very vascular, 25% of the cardiac output, absolutely. And then you're going to apply pressure, but here's where you come into, and this is again state boards, you will be delegating to what? A PCA. And so you're going to tell them, you know that patient's NPO for 2 hours, and they must lay on only their right side for these so many hours. The doctor will specify how much time. He's wanting it to what? Kind of tampen up where he did that stick. So you go in the room and you see the patients on their back or on their left side. Would you tolerate that? No. It's your job, right? It's your job. That's why you have to know what these orders mean. Hey, let's put them on the right side. And then you take them out of the room and you explain why that's so important to adhere to that. Okay? All right, monitor that side as with anything, but the main thing is, do they have pain? Are they having abdominal pain? Are they dropping their H&H or showing signs of dropping their H&H, right? Yes. Shock. Are they bleeding out and now they've gone into hypovolemic shock? Well, I told you the liver is attached to what? The diaphragm, right? Yeah, and so we maybe didn't coordinate their breathing well enough. Maybe I did what? Puncture the lung instead? Yeah, could that happen? Of course it can. Of course it can. It's just like when you're putting a chest tube on the right, in the right lung, you gotta watch out because sometimes they end up, especially when they're learning, they'll put it in the liver. So you just want to watch out. So just the reverse of this. Maybe I punctured that lung, right? Okay. Now I'm pointing you, I'm going to tell you something. ATI has some great things in both lectures that you need to kind of look at. So I'm pointing that out to you, right? Because you have a CME you're taking, a MedSurg CME. And they love all these procedures to test you on that. So I'm pointing that out to help you. Now, again, like I said, liver biopsies, they're quick to do, easy to do, but there's a lot of problems with them. It really does help us stage hepatitis issues. It most certainly does. The problem is the bleeding, the pain, the infection, sampling errors occur. So there's a good and a bad to this. We're veering a little bit away from it. You guys know this. You should know this from certainly adult 1 or maybe even foundations. If I've perforated that bowel in any way or I've caused peritonitis, dadgummit, the guarding, the distension, abdominal distension, the temporizing, they have chills, right? They are pale. You don't even see that discrimination between their lips. They're just pale. And then, of course, the pain, but they become real tachycardic and tachypnic. Now, body's trying to compensate for this blood loss. You have to watch for these things. It's up to you. Just from what? The dadgum liver biopsy, which they could do on a med-surg unit, sometimes in the ICU. Absolutely. Now, let's look now at hepatic failure. So really, when we start having failure, the liver's ability to just do all these functions we talked about, these 400 functions, it really falls below the body's needs. It's just that we've really damaged so much of the liver that there's really an impact on the overall functioning of the body. So here's the deal. So the amount of that liver cell structural changes, the damage that occurs, is really going to tell me the degree of compromise that I have. Once again, I show you on the left the hepatocytes as they should look. That beautiful picture I showed you, that lobule, how they're so lined up. But then when we start having fibrotic, necrotic, edematous changes occurring, you can understand why they get into trouble and these 400 functions become altered. So the damaged liver becomes replaced with scar tissue. Well, that's not good. That's not going to help us any, right? It is not. So the thing is, when they start having cirrhosis, that really doesn't tell me the cause of the liver failure. It just tells me we have issues occurring, right? Okay. Now, these patients could appear healthy, and they may not even know they have liver failure initially. But when we show you some of the signs, you'll see. Okay, patho you can review. It's in your text. I'm not focusing on the chronic issues that you learned about in adult one. Certainly, they are very important. Right now, the major cause of cirrhosis of the liver is alcohol-induced. It's alcoholic liver failure. However, very close to that is NALF and NASH. It's so close, and we're expecting it to tip over. And remember, those are caused by what? Diabetes, obesity, metabolic syndrome, hypertension. Do we see that in this area? Yeah, we got a big problem with it. We most certainly do. Alcohol's still the deal, but it's a close run with this. Okay, drugs. Has anybody taken care of a acetaminophen overdose at University Hospital, or you have? Did they make it? Okay, good. Well, and remember in Karbowski's lecture, what did he tell you about acetaminophen? We don't want to produce, 500 milligrams. We want to do 350. We don't want them overdosing with Tylenol and taking medicines that we don't even know they have Tylenol additionally in it. Yeah, you just see an acetaminophen overdose one time and it will just break your heart. I've seen several die young at University Hospital from it. My youngest alcohol liver failure was 22 at University Hospital. 22, yeah. Alrighty, so we already talked about heart failure and why it happens. Yeah, just chronic. If you look at this, it's interesting. Fatigue, they don't metabolize their food sources, right? But some of these other things, weight loss, anorexia, dyspepsia, flatulence, they're not what? Metabolizing their food sources. That's a problem with it. Steatorrhea is what, and they love this on boards, what does that mean and how would you see that in a patient? It's the fat-soluble the ability to break down fats doesn't occur, and so we get that clay-colored stool that doesn't have the bilirubin coloring it, and the stool's what the doctor will ask them, do your stools float? Right, because it doesn't have the fat in it. Yeah, so steatorrhea, they like to throw these terms around with you on boards. Persistent jaundice, yes. Very sad. We'll look at skin lesions, the spider angioma and the palmar erythema. The reason for those, has anybody seen, I know I have Kiara's here with me, and Kiara has seen spider angiomas. Kiara has seen palmar erythema at University Hospital. Absolutely. And those are due to elevated estrogen levels. Remember, it's a hormone. It doesn't get degraded. So these patients have their very tiny little spider appearances you see them on their chest and their neck and sometimes their face. And I remember one time at BAMC, we had a patient who just rolled into our ICU, and all over his neck and face were the spider angiomas. We didn't even need to know about what the handoff was going on. It was so obvious the patient was in really fulminant liver failure, right? Yeah. And their little palms, even at the bottom of their feet, they get a redness, and it's just elevated estrogen that's causing it. It just doesn't get broken down. They start having anemia issues. their WBCs drop, their platelets drop. I think I'll wait a minute to explain that to you when we talk about portal hypertension, and maybe you already know, which is great. The bruising, the bleeding, big problem, a big challenge with these patients. And it's what? We're not producing those blood clotting factors. We cannot absorb the vitamin K, right? We can't do it. And then we have decreased platelet counts. Really what happens with this is, I told you, these patients get 25% of their cardiac output. And then I start having all these structural changes. So that blood cannot enter that liver. So what's going to happen? Does it have to go somewhere? Yeah, it's clogged. It's like, damn it, I can't get into this liver. Let's just go where the pressure's lower, and it goes to loves to go to the spleen. Great for what immune functions, but it tears up excessive blood cells. So it truly drops your WBC platelet and RBC counts. It's the splenomegaly. Normally, could you palpate the spleen on an examination? No. In these patients, often you can palpate the spleen. It's that enlarged. That's what's causing that. And then affections, you know. SBP, spontaneous bacterial peritonitis. These patients will just suddenly go from a temp of maybe 99 to 103 and go, God, what's going on? It's usually from this spontaneous bacterial peritonitis issue. Yeah, that's what's causing that. So we'll talk just a second. So let's just think here a minute. If I can't get all this blood into the liver, right, and I can't, and it backs up into the spleen, what happens to the hydrostatic pressure within that portal vein? What does it do? It becomes elevated. So just because of that alone, it does what? It pushes the blood interstitially, right? And that's one way how you get this SBP. Another thing is this. I told you a third of the thoracic duct lymph production comes from the liver. When it starts altering and getting into cirrhotic issues, literally you have lymph that, since it cannot go through the space of D's and into your lymph system, it just starts dripping off of the liver. And so that causes more fluid to accumulate. So it's just an interesting phenomenon that occurs with these patients. Where did I put that clicker? Up here? Yeah, I want to show you one other thing. All right, so cool. Very cool. Look, I told my husband the other day, I said, oh, Danielle, I love that liver. He's an attorney. He doesn't know anything about medicine at all. And I said, man, I remember when I fell in love with that liver when I was in my BSN program. I was walking to the library and I was reading and I was like, oh my gosh, this is incredible. So many years ago. All right, so look at this. These are what? Those spiderangiomas, tiny little. They're tiny. And all you have to do is you press them with your finger, they blanch, and then they spider back out. And it's showing you, look at some liver failure going on, right? So one day, the beauty of this is, the beauty of starting out in a tertiary setting when you first graduate is this. You learn all about DKA. You're going to see HHS. You're going to see liver failure. You're going to see hypertensive crisis, right? And you're going to know the devastating effects when it's not managed appropriately, right? So then when you want to become that advanced practice nurse, you're going to be credible. They're going to listen to you because you know what happens if it's not managed right. Really? Yes. Yes, absolutely. We had some problems in our home with some windows needing replaced. A guy came to give an estimate, and all on his neck and his face and upper chest, he had spiderangiomas. Oh my God, this man's sick. Does he know he's sick? I've never met him before, right? And so he's telling, yeah, you need 22 new windows on. I said, hey, are you okay? Talk to him. He said, well, you know, I've been drinking a lot lately, and you know, I got to see you this one. Oh my gosh. And then he starts telling me more. I said, listen, you need to get help. Your liver is not functioning well. This is just from what? Spiderangiomas. Yes, he was in trouble, needed help. Okay, they can develop breast tissue. We're not breaking down the estrogen. They get testicular atrophy. They start developing neuropathies just from the lack of vitamins. And then again, they're not metabolized in the food sources. They are cachectic. Very, very bad. They're very wasted away. Their neck is just very, you can literally, you don't even count intercostals. You see them. Yeah, their arms are wasting. And then they've got the big ascites. Okay. Why would I start having dysrhythmias if I'm not going to have an effective circulating volume because of the albumin issues I'm third spacing? These patients have electrolyte issues too that we'll discuss in a minute. Yes, they do. And so because they don't have an effective circulating volume, they get real tachycardic. They're trying to compensate for this loss of an effective circulating volume because of the albumin, low albumin issue. The jaundice, you understand. You see this in this picture. And it can be extremely exaggerated just like this. It will be. They just almost glow. It's that bad. We talked about the effects of the bile production. It just doesn't get synthesized as it should. So we see the problems with the fat-soluble vitamins, and then we'll talk in a minute about again bilirubin. Here's our problems. They were pumping along. And the thing is with alcohol, liver failure, alcoholic-induced liver failure, do I know exactly how much alcohol it takes to cause the liver to fail? No. We do know women are more sensitive to alcohol and its damaging effect on the liver than men. But, you know, it's not like, okay, this much, you're safe. There's a lot of interesting thoughts on that. So, here we go. Here are the 5 issues. Portal hypertension, I have decompensated. I'm no longer in the chronic state. I'm going to have esophageal and gastric variceals. I'm going to have the excessive ascites and peripheral edema, especially lower peripheral edema, hepatic encephalopathy, and then HRS. So portal hypertension. Okay. I told you that liver receives a tremendous amount of blood. It's huge. So here you go. I love all this cardiac output, but suddenly it's no longer this big. It's cirrhotic, and it's now this big. Can it take all that blood supply? No. So we develop portal hypertension from it. So what will we see? Splenomegaly. It's going to just eat up all your excessive blood cells so they drop. They most certainly do, and I will be able to palpate that spleen. Alrighty. I could also see in these patients hemorrhoids. Internally, you might see some bright red rectal bleeding. It's just because I'm diverting that rich blood supply, it can't accept that portal vein, 70% of the blood. It just can't accept it, so it's diverting it. So they do get internal hemorrhoids. They also will get hematochezia. So what is hematochezia? What does that word mean? It means the stools are bright red blood. Okay, they're not melanic. They're bright red. Okay. Now, what about Caput Medusa? What is the goddess of Medusa had what on her head? Snakes. That's all that means. I had put in another slide, but I don't think it uploaded. I'm going to reload. Just like this lecture's fine, but I reloaded 2 pictures. If you need it, I can do that. Yeah, they'll start getting really exaggerated Caput Medusa, absolutely. And then we'll talk about varices in a second and ascites. You see that on there, how it just, this is very obvious. Yeah, they're so sad. And they've made bad life choices often in life, and so they don't even feel worthy of care. Maybe they've caused a lot of problems with their families, and so their esteem is really not good. But they're so wonderful to take care of. I always love caring for them. And my heart goes out to them. I'm not there to judge, I'm there to help, right? Absolutely. Yeah. Variceals. So, if I told you I'm getting all this tremendous blood supply, and now it's cirrhotic, and it can't get that portal, that 25% of that blood, cardiac output, it will not go. It's congested. What happens with variceals? Esophageal varices especially. You're going to hold on to this one in a second. Thank you. Just put it up like here. Okay, so there you go. I have a small cirrhotic liver, and it can't get all that blood volume, so that's okay. No, so it's fine. I'm going to deserve it because and it's like, great. I can handle this. But then the surge of the blood starts getting more and more. Can these dilate forever? They're ultimately going to rupture. And they're going to bleed. And trust me, with a sudden rupture of esophageal varices, it's not like you're going to get a little emesis space and for them to vomit in. You need a trash can. It's like blood everywhere. They can bleed to death. It's that dramatic. This is all that's happening, right? That's it. Ah, thank you so much. All right, and we'll go into care for them in a minute. This makes sense, right? Absolutely. Yeah. Melena, just those. How many have seen melena? You don't even have to see it. You know the what? The smell. It's so characteristic. You can just go, melena. You know, that's it. Yeah, it's a maroonish, dark brown, blackish color, but it has a very distinct smell to it. Yes, absolutely. And then again, these ammonia levels, they're going to go way up. Okay, well, just a minute. Ascites, I've already told you, portal hypertension, hydrostatic pressure. It pushes fluids out into the interstitial, the abdominal cavity. I'm not making albumin, so I don't hold onto the fluids intervascularly. They third space. I told you about the lymph linking from the capsule, even through that Glisson's capsule. I have elevated aldosterone and ADH. All of this will result in ascites, every bit of it. And then we talked about the SVP. Suddenly you'll see it. It may be the next hour, you go, whoa, what happened here? The breast sounds haven't changed. And maybe even not even the abdominal distension. You know, it would be, you watch out and you need to call a doctor, the provider, and say, hey, just had an elevated temp go from 100 to 103 like in an hour. You need to let them know. Okay, and you can see how miserable they are. They're so miserable, right? You know, one thing that's interesting about abdominal distension, have you ever with a patient so far had to track the amount of distension they have? Is that kind of hard to see if it's getting worse? Well, it is. Honestly, it really is. It's not as easy. It's not like it's going to go, no. But what I would tell you to do in your clinical setting, if you're suspecting any kind of abdominal distension issues, is just to take an alcohol swab, don't even take it out of the package, and mark it here, and then mark it here. As that distension starts getting more provocative, what's going to happen to those two markers? They're going to lengthen. Measuring the abdominal girth is hard on these patients, but I like doing that. It works nicely. And the doctor will say, hey, you know what you're doing. You know, it's a good trick. It's very helpful to use that. So you see how miserable they are? Absolutely. Weight gain, of course, but it's not good weight gain. That everted umbilicus. We talked about the distended abdomen, the stria, just from the distension of the abdomen. They start having peripheral edema. They don't have a good albumin level. They start third spacing. Well, decreased breath sounds, the more abdominal distension. Can they really execute and work against that? Their diaphragm is being pressed by what? Excessive abdominal distension. Very hard on them, so they get dyspneic. Crackles start occurring. The urinary output decreases. We'll talk about that in a little bit. That's a very important finding with these patients. Their effective circulating volume is poor. So they can immediately go into a pre-renal, but then they slip into that intrarenal issue. So you have to watch them. So the urine becomes real concentrated. And you can see that. I'll put these slides up. It looks like Coca-Cola. And the doctor will even ask you, what's the color of that urine? And you'll say, hey, you know what it's like? Looks like Coca-Cola. And it even has like froth on top of it. And they're like, all right. We've got an issue. Yep. Okay. Now, hepatic encephalopathy. What does encephalopathy mean 4 words. Dysfunction of the brain. That's what encephalopathy means. However, what word precedes that tells me why that brain is dysfunctioning. So if I put anoxic encephalopathy, why is the brain dysfunctioning? Lack of O2. If I put hepatic, what does it mean? The liver is failing and it's causing me to have encephalopathic changes. Absolutely, absolutely. And really, probably the most important reason is my liver is unable to convert ammonia to urea. And it's this high ammonia levels that start causing this confused state. It can be other things too. It can be from electrolyte derangements, imbalances, whether it's a high or low glucose. It can be, we're going to see cerebral edema in these patients when we talk about fulminant liver failure. It could be alcohol withdrawal, right? Yeah. But the problem is, this encephalopathy really alters their quality of life. Now, the thing with HE, hepatic encephalopathy, is that it causes these funky changes in these patients, and we understand why it occurs. But you really need to protect these patients and understand the stages, and we'll talk about that in just a second. But the problem is the high ammonia levels are very toxic to the brain, very, very bad. And ammonia can cross that blood-brain barrier, and that makes it even worse. And so the brain starts really faulting. It doesn't perform like it should. And you have abnormal neurotransmission, astrocytes swell, and you have the kinase released. So it's really bad. It not only alters their sensorium, but it truly can really affect their brain functioning. You will use a grading scale. It's a 0 to 1. There's a nice picture of it in your textbook. And they will talk about that when they're rounding and put it in their notes. It's really, really important to know those. But they'll start having impaired consciousness because of these high ammonia levels. And they just don't think straight, and they talk odd, and they do really random things. So I have a cousin who passed away 6 years ago. She was 62 from alcohol-induced liver failure. And she would just do bizarre things. You know, her night and days were flipped. She would go outside and just bash all the windows in the car. She couldn't help it. It was because of the high ammonia levels that were causing this. So they have inappropriate behavior. Their sleep cycle, they're asleep during the day, they're up at night. It's just really hell. It's hard on them. Now, here's another thing. When you round with the doctors, so you're a liver failure patient, and I'm rounding on you, and you're the nurse with me, okay? And I'll say, okay, would you hold this a minute, honey? And I'll say, I want you to do this. Put your hand. Has anybody seen this in clinical yet? And they'll say, just put your hands out straight for me. And you're like, well, what was that? They'll do this. It's called asterixis, and that tells me the ammonia level is what? You're going to see that on that CME. I promise you that's their CME. And say, well, who cares if they have this liver flash? Their ammonia levels are going up. You let them go too high, they can become comatose, okay? You've got to watch them. That's asterixis. Apraxia, they can't even sign their name, so we'll trend them. We may not even have to do an ammonia level. We're going to know the score, right? They'll have that fruity, musty smell to their breath. And just notice the little pictorial diagrams here. You're going to see that for sure. Now, do look at your book on the 4 stages of HR, of HE, hepatic encephalopathy. So if I have a patient who's at stage 1 and they go to stage 3, you're going to watch them. And you have to help the family understand what's going on. The majority of it's really related to high ammonia levels. So we're going to have to really work to get those ammonia levels down, and we'll talk about that in a little bit. But what about HRS, hepatorenal syndrome? Do these patients have an effective circulating volume? No. Remember, they are low on albumin, right? And that's a positive oncotic force, so they don't have an effective circulating volume. So they go into hepatorenal syndrome. So their kidneys start falling, and it often is seen suddenly. You're trending their creatinine and creatinine clearance, and you're seeing funky things occur. The problem is initially, there's really no kidney structural damage to it. It's just, it isn't initially. But the reason for this is that they don't have, bottom line, an effective circulating volume. Really, that's the main issue that occurs. So they go into acute renal injury, which is not good at all with these patients. So when that occurs, you're going to have to start being sure that you're giving them adequate fluids. You're going to give them albumin. You may have to give them vasopressors and get their MAP at least to a 65 to ensure perfusion's occurring. They may have to go on dialysis. We're going to watch this creatinine to creatinine clearance ratio closely. They are funky with this. There's more to this than really this slide alludes to, but that ratio doesn't often really tell the degree that they're in, but we'll watch it. We're going to very much watch it. And if it gets bad enough, we may have to do what? A liver transplant. Okay, so is it time for a break? All right, let's take 10 minutes and what? Care. It's no longer nursing care, it's what? Routine. We've got to do these things together to help our patients, try to make them get at their best of ability, right? And it is not moving forward. Okay. Okay, that's okay. I can get it. We were on. Okay. Questions while we're trying to advance this forward? So we're going to talk about care. You will be doing a case study that you'll get points for, okay? Good. Okay. As you can imagine, these patients have fluid imbalance issues tremendously. Of course they do. If you surely think of the increased hydrostatic pressure that occurs from a cirrhotic liver, that pressure would push fluid interstitially, but also the low albumin. That causes a lot of issues with third spacing, that alone, because albumin's made in the liver, and so we start having a lot of problems with that. So our problem, our challenge as an interprofessional team is we've got to try to control this fluid accumulation, and that is a challenge for them. It most certainly is. We want them to have what? An effective circulating volume so they can perfuse all these organs, but it's challenging. It's not as easy as it sounds. We certainly would put them on sodium restriction. There's no doubt about that. Now, diuresing, we're going to do a walk with spironolactone and furosemide. Now remember, spironolactone is what? An aldosterone antagonist. And you learned all about that in pharmacology. We're going to do a walk with these two drugs because we know that we do have to diurese them, but we have to do it very carefully, okay? So the problem too is when we're using diuretics, we've got to start watching their electrolyte balances. And as you can see, we want to monitor the sodium. We want to monitor their bicarb, their BU and creatinine, and their K. So you're going to be watching that BMP. You're going to be trending these labs. And the doctor, again, they're there, 10% of the time. You're there 90%. So it's really on you to do this lab analysis and start trending this. As you can imagine, with a low K, which can certainly occur, it has very damaging effects to these patients. And so it will provocate cardiac dysrhythmias. You want to watch for that. They can get tachycardia, blood pressure will drop. And so it causes generalized muscle wasting. They're already at this point so weak. I mean, they really are, that they can't even turn themselves in the bed. They're that weak. We're going to have to put them on a fluid restriction and watch that. How much are we giving them with antibiotics? How much crystalloids are we infusing? All of that. We're going to and so it's depleted. So we want to watch for that. And you would think, you know what, but with a stress response, we tend to do what? Have a higher glucose level. They've used up all of that, so often you're going to see more low sugars. The sodium can go in either or. It can go high, it can go low. So once again, it's for you to be watching for that. Remember, we have elevated aldosterone levels. Aldosterone is a hormone, right? And it loves what? Sodium. And so sometimes they'll have a high sodium, and it can also be because of what? They are dehydrated, their third spacing. But they can also become low in their sodium. So you have to watch them. You just have to watch these. One drug that we give often at University Hospital is Zolvaptan, and that's really what, in essence, it does is it just encourages water secretion so that I don't have this dilutional low sodium level. So we use that often there. Acid-base imbalances, you had a great lecture on that. It's for you to watch on these patients. You're not going to be doing ABGs hourly, but you're going to be watching your patient. So if your patient goes into renal failure, which remember HRS, hepatorenal syndrome, they go into AKI, right? And they can go into intrarenal failure. So you've got to have this in the back of your head. Anatomy, physiology, pathophysiology in all of these patients, even in adult 1, is really what starts you thinking of how am I going to manage my patients. It's really the bottom line. And it makes you really appreciate how you're caring for these patients when you understand it and apply it at that level. So with renal failure, remember what happens with these patients is in renal failure, they start holding on to what? They have high hydrogen levels, and so they become acidotic from that. Okay, they most certainly do. Ketoacidosis, absolutely, that can occur too with these patients. And where we see it is if these patients suddenly are alcoholics and they stop drinking, they just suddenly stop. The problem that occurs with them is they really need that carbohydrate from the alcohol, and suddenly they're no longer getting it because they've stopped drinking, and so then the body starts breaking down protein and fats, and they go into this acidotic state. You remember that singer? She was from England, and she was struggling. I can't think of her name. She was struggling. What was it, Amy? Yeah, I'm sure how she died, because remember, suddenly she was gone. I'm sure this is what happened with her. She was trying really hard to stop drinking, and then we heard, gosh, she died. I would think this is probably what happened. Respiratory alkalosis. So here's the thing. They have this tremendous ascites. They're hyperventilating, try to oxygenate, and so they become alkalotic. So you just have to keep these things in the back of your mind and watch them. Often, of course, they're going to be intubated, and you're going to manage them, sedating them, and manage them with a ventilator. They're that critically ill. They're very sad patients to take care of, especially when it's alcohol-induced. The ascites, we've seen how provocative it becomes, the third spacing of fluids. And so with these patients, it's so important to have accurate INOs, to be watching their daily weight and that abdominal girth, distension of it. I honestly don't see people measuring it anymore, not in the ICU setting, but certainly just putting that alcohol swab, marking that on either side, and seeing it expand usually is very helpful. Doctors know you're thinking right for your patient. They love me taking care of them. Paracentesis, yes, we will have to do it. It's more of a palliative effect to make them more comfortable and help them breathe easier. It's going to reaccumulate. So it's more of a palliation approach. And so, explaining the procedures. At this point, it's explaining it to the family and getting them to sign an informed consent. Prior to, we of course weigh them. And these patients have a folium, so they're not going to be able to void. If they're on a med-surg floor, sure, we can have them void there. Okay. We might give some albumin prior. Remember, albumin is a positive oncotic pressure, and it might pull in some of this third space fluid and give them at least a robust pressure, which we all like and need. And then certainly, we want to be monitoring the INR. We know they have a tendency to have an extended INR, because platelets are being destroyed from splenomegalia, and we know also that we're not absorbing that vitamin K, that fat-soluble vitamin. So it's a dual approach, right? Yeah. They're going to be supine, and if they can tolerate, you're going to put the head of the bed up, right? And have them relax, and then they just do a random puncture. So here's the thing, and then withdraw X. Your book might say, yeah, they can withdraw up to 5 liters. Well, I challenge that. I have a great friend at University Hospital who this is just his expertise. He's an acute care nurse practitioner. He's withdrawn as much as 22 liters when these patients are in this kind of situation. So you can imagine the amount of fluid that they can accumulate. It's really a lot. So if, let's say, we're going to do a paracentesis, if these patients have a fully in, they're that critically ill, they're not getting out of this, they are that bad at this point. So we will totally write down how much did they drain through the paracentesis. It's a random stick. They just do a random. They'll have some ultrasonography there with them guiding them, and bam. And then they start withdrawing the fluid. Okay. So we have to record how much was withdrawn. They send it to lab because we know they can develop what? Spontaneous bacterial peritonitis. So let's just see if it cultures out anything. And again, we're withdrawing a lot of fluid. Tom has withdrawn upwards to 22 liters. So let's watch for what? Drop in their pressure. Anytime you do anything, you're here because you're smart. There were many that could have filled these spots, honestly. There were 2/3 that didn't get in. You were the third, those that were chosen, I kid you not. And so we're proud of you. We know you're smart. So you want to be thinking this way and helping these patients tremendously. Let's see here. Post, hey, it's fine. You might have a tech like an ICU, the MICU at university. They have their PCAs helping them, and we have them on monitors. Watch those vital signs. Watch them carefully. These patients are unstable. You are their eyes and reporting to the provider to prevent them from what? Coding. Absolutely. The labs are sent. Let's see if there is any kind of infection with the SBP that has occurred. And let's watch that puncture site because sometimes it drains and sometimes we really have to put a collector in it. And it's straw colored. It's not clear. It's usually straw colored. So watch the amount of drainage. Watch. It's a blind stick. We use ultrasonography when it's being done, but it's a blind stick. So man, we could perforate the valve. So we would watch for any kind of signs of peritonitis occurring. And then once again, they're already low on effective circulating volume. So you want to watch carefully about that. Often we'll give albumin because it's what? A positive oncotic pressure. It will hopefully pull in this third stage fluid to elevate their blood pressure, right? So we have to watch, and we have to know why we're giving what we're giving. We have to know why, how I'm giving albumin, but why? I want to maintain an effective circulating volume when I'm doing any kind of procedure, but certainly withdrawing all this fluid from these patients. Okay. You can look at ATI is nice. Remember, ATI is like a cliff note, but if you understand this, you can go in and I get this, and be ready for what that CME. Yeah, it's nice. I like it. I like it. Okay. We talked about HE, hepatic encephalopathy, right, dysfunction of the vein. We love to give rifaximin, and it is a regional antibiotic. It literally will sterilize the gut, the GI system. It's regional, it's not systemically given, or it doesn't work systemically. About HE, hepatic encephalopathy, right, dysfunction of the vein. We love to give rifaximin, and it is a regional antibiotic. It literally will sterilize the gut, the GI system. It's regional, it's not systemically given, or it doesn't work systemically. Of course, flagyl and vancomycin do. But we love to use rifaximin on the liver failure patients. And so what it does, like I told you, it works in the gut. It's very effective, and it prevents these patients from having these high ammonia levels. It's very effective. It's a wonderful drug. It has really transformed the management of the hepatic encephalopathy is that one drug. Wonderful drug. Okay, lactulose. How many have given lactulose? Yeah, so elderly, we can use it as what? Yeah, we can use it as a laxative. In these patients, truly, what we're doing is it literally will trap the ammonia, and then it's excreted. So we will lower that ammonia level, which is the main problem in causing this hepatic encephalopathy. So we do use lactulose enemas, and also through the NG2 we'll do both. It does cause diarrhea, and those patients who are on your med-surg floors and not in the ICU setting, they have to just take it daily. And they'll say to you, oh, I don't take that anymore. I don't like taking that drug. They really don't, because it causes what? Diarrhea. And here they are already sick, and they have what? Ascites, and they're miserable. And now I'm giving them something that's going to cause diarrhea. It's hard for them. But it's essential. It's essential, because it will pull down those ammonia levels so they don't start having dysfunction of the brain. Okay. We want to have high carbohydrates. Protein, yes, they need it. It's essential for life. Now, the problem is, what is the byproduct of protein metabolism? It's ammonia. And you're like, oh my God, here we go. You're telling me to give them protein. Often what we'll do is give them what? Branched chain amino acids, where it's already been broken down to avoid the elevation in ammonia. But they have to have protein for life. Absolutely they do. Sometimes you've got to watch its effect on their ammonia levels. Moderate fat, you don't want it, you want moderate to low, because remember, we don't have what those fat-soluble vitamins are working, and we can't emulsify the fat. Low sodium, we know why for that, and so there you go. TPM, absolutely. Enteral feeds, they're usually not, they're going to be on TPN. Okay, Dr. Cleveland. Okay. So here we go with the question. Your LPN tells the RN the client with liver failure is getting more confused. You're like, oh, okay. Is it ammonia? Probably. So what intervention should the nurse implement first? Would you assess their neurological status? Would you immediately call the provider? Would you say, hey, let's do a stat ammonia? Or would you tell that LPN, hey, go get their vital signs for me? So, you know what? Assess their neurological status, right? Because remember, that ammonia does what? It affects them neurologically. It's hepatic encephalopathy. So see their axis, see how oriented they are, see if they're confused. That's what you want to do first. It will tell the doctor a whole lot. Now, if the patient's intubated, asking those kind of questions you can't do. If they can cooperate with you, if they're that strong and put their hands up and see, if they have atherosclerosis, yeah, you can try. At this stage, usually they're too sick to do that. They have a tremendous proclivity to bleed, and often they bleed to death. That's a big problem with these patients. When the esophageal varices rupture, it is a nightmare when they rupture, when it's really bad. I mean, blood goes, it's terrible. You see it once and you never forget it. So we want to avoid bleeding and hemorrhage with these patients. Of course we do. So we know they're going to have esophageal varices. We know they've developed portal hypertension, and a sequela, that is what varices. I'm already thinking, because remember, you're planning ahead, you're anticipating. You walk into that room and you have all this knowledge to take care of them beautifully. Okay. So of course, avoiding alcohol, NSAIDs, aspirin. This is before they're in the ICU setting. We would want to teach them those things if they're handling this okay at home, right? They are very, they easily get pneumonia They have ascites. They are not having a good excursion with their lungs. Their immune system is compromised. So we want to treat respiratory infections. We don't want them coughing and then causing these variceals to rupture. We want to really be careful with that because they rupture. You see it one time and you'll never forget. I remember the first time I saw this at the VA. It was on a med-surg floor and the patient was in the bathroom and just started immediately had the it was 28 years old, had to transfer him to the ICU. So it's very provocative. It's not like a sudden, it's like you're on. It's very dramatic when it occurs. So you don't want that sneezing, coughing, right? Yeah. And you may not see those signs and symptoms until they have a massive rupture. It's certainly, absolutely. Okay, so what would you do if you had these rupture? What is your role going to be? So they start massively bleeding, you're there alone, you call for the providers, you're at university, and you have the residents come flying in, and they see what's going on. Now, if their blood pressure's in the toilet, forget putting the head of the bed up, right? But if they can handle it, fine. And then turn them on their side so they don't aspirate. If they haven't been, intubated? Absolutely. And support their airway. Hopefully, mainly what we see at university and the VA is they're intubated. Okay, so that's a blessing. At least you have that. Just watch their vital signs. Watch their stats. See how they're trending. Be aware of your ventilator settings. Be aware of the amount of O2 augmentation you're giving them. You are going to be talking to them and telling them they are in the middle of keeping these patients alive. This is very sad when they have ruptures. They have to have IV fluids if they are already there. We're going to give them fresh frozen plasma for the clotting factors and the volume. We'll give them packed cells too. We will always be watching labs. There already should have been type and frost, but your mind is literally thinking so fast when this occurs. You see it once, you go through it once, and it's very dramatic. This is not easy on the patient, on you, your staff, and if the family's here, it's really rough on them to see this occur. NG2, now, there you go, putting one down. You don't want to irritate these variceals, right, and make it worse. So that's a walk. You might put in a Levine tube too. So once we do get in the tube, if it's already in, we'll start lavaging them. We're going to have to start lavaging them with normal saline. Give them vitamin K, chlormethadine, put them on proton pump inhibitors, and MPO. If they can, if they're even stable, doing an EGD, usually in the ICU, they can't even go for that, guys. They're that unstable. You just have to keep a blood pressure up on them, keep them breathing, keeping an MAP above 65, and just managing them the best you can, right? All right, now let's talk about the Blakemore tube. Let's talk about that. What I want you to do, has anyone seen a Blakemore on a patient yet? In the ICU or in the ED inserted? Yeah, I wish I had one. They cost about $500 to $600. I looked it up to find, we need one because you need to see this thing. It's really funky to look at. Okay, so we're first going to go what we would do first, and then we'll go into a Blakemore. Okay, so we can do what? Endoscopically, we can go down and look at the esophagus and see those variceals. And there's several things that we can do. We can inject them with a waxy substance to block off this big blood surge that's coming from portal hypertension, right? So we can demoruate, we will. But the preferred method is really banding. So they'll go down with a scope in the distal part of the esophagus, and you'll see it if they show it on the screen. And they'll literally snare that variceal where it's dilated and then band it so that the blood flow ceases to that area. Because they literally can die from just ruptured esophageal varices. And I've seen, honestly, I've taken care of these patients so long, I've seen quite a few die just from this. It breaks your heart. It really breaks your heart, but yes. Now, pre-banding, of course, consent, the families or significant others going to have to do that. They have to be sedated if they not already are in the ICU. But after it's done, you're on. because the provider's not going to stay there. But you've got to really watch these patients. Watch how are they trending with their vital signs. You know, is their MAP dropping below 65? We used to be comfortable with 60. We're not anymore. We want an MAP at least at 65, right? Yeah. Yeah, because in MAP, mean arterial pressure, what does that mean? What is the definition of a mean arterial pressure? Really? So it's the perfusion necessary to perfuse at the cellular level. So you stop, you go below a 65, your cells aren't going to get perfused. You're going to start having end organ damage. So you've really got to watch for that. I told you about the banding, what we do. So I need your help again, right here. Thank you. So if I'm doing an ECG, and I go down there, and I've got this endoscope in the lower part of their esophagus, and I see that bulging, I'll snare it, I band it, and we put a little band on it. That's what we do. Okay? That's what we're going to do. The problem with this is, looks like that's all easy and all, but you've got to watch, because anything we do, we could have some great outcomes, and we could not, because that's you to be watching for this, because you're there 90% of the time. The provider is there 10. Okay. So it could have some superficial ulceration that could occur. We could have some little strictures that can occur. You can see dysphagia. Well, that's really not an issue with these patients. They are trying to stay alive. We're trying to keep them alive at this point. All right. But the problem is, too, it could bleed. I could perforate the esophagus from this. Absolutely. There's many complications that can occur from this little bitty procedure that doesn't take that long. We could cause strictures to occur. We will just prophylactically give them what? Proton pump inhibitors, some antacids, absolutely. But we've got to get these banded. We have to, or else they're going to bleed to death. They will. It can be minimal bleeding, or it can be so bad, you're like, oh my God, they bleed to death. And if you're in the ICU long enough, you're going to experience this. You will see it happen. Yeah. So it's sad, especially if the families they're seeing this. Very tragic, right? Okay. Review it. Nice. Question. Esophageal bleeding. What is sign? So here you are. You're the nurse. It's your patient. You're in the ICU. And you see the H&H at this point, hey, it's not so bad, right? It's low, but it's not terrible. We start giving back, transfusing in the ICU, sometimes as low as 7 and 21, maybe 8 and 24. But so 11 and 32, yeah, abdomen is soft. Okay, would you be worried about that? No, usually they have ascites. Look at those vital signs, 88/60, a heart rate of 119. Would that bother you? Oh my God, yes, that's the one. You want to, oh, no. You do a call to that provider and say, we've got problems. What we are doing, what we have done is not working. This is the issue. This is a big problem. That patient's tachycardic because they're losing volume. They don't have an effective circulating volume. They're bled out, right? And then if it's coffee ground emesis, are you going to be worried, or would you be worried about bright red bleeding? Bright red. Right? Coffee ground's been in there for a while. I wouldn't be as worried. I'll let them know. But if it's bright red, so hematemesis just means I'm vomiting blood. So it could be coffee ground, it could be bright blood, bright red, right? Now hematochezia is what? Bright red rectal bleeding. So that's just it. So it's really those vital signs. You're there with them. You're trending these things. It's up to you. It's up to you to let them know what is going on. Yeah. Okay, octreotide, I love it. We used to use nitroglycerin. It's a big problem managing that. But octreotide is a lovely drug. It's cheap. And we use it on these patients. We'll even use it prophylactically when we know they have esophageal varices. And so the problems with it are minimal with octreotide. It may, sometimes you'll see, don't worry about that. You can see an ECG change you have to watch. You can see a prolonged QR, QT interval, but that's kind of like at a higher level. Don't worry about that. And then we talked about doing the endoscopic gastroduodenoscopy to look at the dilations. And I talked with you about the banding and about the sclerotherapy, okay? When they're bleeding really bad, they can certainly go into hemorrhagic shock. So you would be watching that tremendous drop in pressure, that acceleration of the heart rate, and then you're seeing slow capillary refill. They're very pale, and you're in big trouble when that occurs. So this is interesting. Balloon tamponade. I want you to, wherever you are clinically, to ask in the MICU and to ask in the ED, do you have a Blakemore? Because just looking at this on this photo here, it just doesn't do justice to it. But ask your faculty, say, hey, can you find a Blakemore? And we can look at it. You look at it and you're like, gosh, I know why this thing's used. It's a last-ditch effort when we start using this Blakemore, but they like to test y'all on this, on boards, okay? So if I can't control the bleeding from the esophageal varices, I'm literally going to put this in this, I'm going to put it through their nose, an NG tube, but you notice it has several little dilations of balloons in it. So I'm going to insert it, and I'm first going to inflate the balloon in the stomach because I want to anchor it in here. And then there's a big long balloon here in the esophagus. And when that's inflated, it puts what? Pressure against the variceals, and they stop bleeding. That's truly what it does. Okay? They like this on state boards, questions on this. So you'll secure it up there near. We used to have them in we'd have a football helmet on them because we had so much of this. We didn't have these wonderful drugs like triatide then. We didn't have romazicon. We had a mess on our hands. So we would anchor them to the shield on the football helmet to keep traction. So it would stay here in the stomach, but then it would keep pressure on the esophagus. Today we don't use that, but you will have pressure. You're going to have 3 tubes, one to inflate gastric and one to inflate the esophageal balloon. And we're just literally trying with this balloon here. This anchors in the stomach. This is just putting pressure on the vessels to kind of, so if you remove an IV, what's the first thing you do to stop bleeding? Just apply pressure. That's all we're doing here, right? That's it. If it works, okay? Anyways, they're bleeding out, watch their pressure, watch their heart rate, trend those, watch for them. It's secured no longer with a football helmet on the little guard. It's secured with a little, God bless you, a little like padding, a little pillow, kind of little adapter. But anyways, you secure it, but then just watch it, because let me tell you what can happen here. As with anything, you're their eyes and ears, right? Maybe it's my husband that's having this happen, and I want to know that y'all know what to do, that you're on and you know what to do. This works. It's a last-ditch effort. They love to test you on this on the CME and also on boards. Not used that often because we have too many other things we can use prior. But let's say I lose this here, the inflation here in that gastric balloon, which is below the cardiac sphincter. What will happen to this balloon here that's in the esophagus? It's going to migrate upward, and then how you know it's migrating upward is they start having respiratory compromise. So when that happens, and you know that you have an airway obstruction, you're going to literally have to have scissors at the bedside and just cut that tube. You've got to put airway first, right? So you'll have pristine orders about this of what you do, but you have to always, you are what? Watching that patient. They're yours. That's a loved one. It could be my family member. Sometimes, too, these can be so inflated that they literally can rupture the esophagus. That's deadly when that occurs. But you would see signs of what? Hemorrhagic shock. They would have dropping of that blood pressure. The MAP would be very, very low. You just have to call for a code and get help immediately. Unfortunately, they can aspirate, and then there you go. You've got aspiration pneumonia. They're very difficult patients to care for, and they're sad to take care of. Breaks your heart, but they desperately need you. Oral care, check for sinusitis, see if they can make it through that. Again, they can get confused. They already have higher ammonia levels from this, right? And so you just don't, if they have any kind of strength in them, be sure they're restrained so they don't pull it out and cause more damage. I would review the CME book prior to that test, med-surg test, because you'll probably have questions on it. We love to give them propranolol, Inderal, Coreg. We give them this. Beta blocker, it's non-selective, but all it does is it will decrease that portal pressure, and so it slows the esophageal bleeding. They will be, and sometimes prophylactically we just put them on propranolol. Absolutely. This is chronic. You learned about TIPS procedure in chronic. These patients that you're getting that are decompensating, this is beyond that. There's no longer this can help, right? But it's there as a review, but I won't test you on it because it's chronic and in yellow. This again too, I really haven't, I don't know if Dr. Stoltz is here, I haven't seen him do shunts in years, honestly. My clinical site has always been University Hospital. Prior to that, VA and BMC. For a while we had a clinical site at BMC. But anyways, I don't see them do shunts anymore. But literally what they're doing is they're trying to prevent what? The portal hypertension. So they're going to reroute things. I just don't see it done very often. You know, and it's really done when they're in a chronic state, not in an acute state. Okay? Of course, nutritionally, they're very impaired. They're going to require caloric counts, TPN. Enteral feeds, if we prefer that to TPN because central line infusion, the cost of it, the problems with them possibly getting infected, it's good, but you're going to see either enteral feeding or TPN. One or the other is going to occur with these patients. So the dietitian who rounds with you in the ICU at least once or twice a week will help you to decide what kind of nutritional intake they need. So of course, high carbos, high protein, knowing that I've got to watch for the ammonia levels, right? But I'll have them on lactulose, and I'm going to have them on rifaximin. And then low fat and watch sodium. Okay. Tissue integrity, of course, you know, they're swollen, they've got ascites, they're weak, they just can't move much, and so you want to be watching for skin integrity issues and just your basic things that you would do. And you learned all about taking care of the jaundice, the side effects of those bile salts. When they depose on the skins, the deposition causes intense itching. These patients are too sick to scratch. So that's more chronic related, and that's why I had it yellow. Okay? They're too sick at this point. Ours are very, very ill. Of course, they can get infected. Absolutely, they're very compromised. The Kupffer cell activity has been altered because of the chronic liver failure, the acute liver failure. Their immune system's depressed. They have splenomegaly, so WBCs are low. So, and they're malnourished. So they're a real challenge to take care of. It's very sad, taking care of these patients. The youngest one I've lost was a 22-year-old at University Hospital. It broke my heart. She started drinking around 12 or 13, and it was alcohol-induced. It just was so sad, very sad, and we couldn't help her. So of course, if you're that weak and on bed rest, you can imagine that they can develop VTEs. You're going to have to be sure your scuds are on sequential compression devices. You're turning them. You're going to watch and prevent these injuries. You may think, well, what's the big deal about the SCDs? No. All of this is so important. Honestly, it's so important. Let's prevent ventilator-acquired pneumonia. Right, let's prevent that. And you had that lecture. Have they had that lecture? Have you had it pulmonary yet?
Yes.
Okay, there you go. You got your that bundle, right? Yeah. Ventilator-acquired pneumonia. They will be intubated. Okay, now most of them at this point are what? Intubated. So really, the communication issue is very, very compromised. They're critically ill. But if they are in alcohol withdrawal and they're not intubated, they'll have hepatic encephalopathy because of those high ammonia levels. And tragically, like we talked about earlier, they can develop cerebral edema, and then it's really bad. mean, their electrolyte imbalances are wacko. So you have to anticipate how they're going to go and be watching for those signs and symptoms, and then do what? Report it to the provider, telling them where you're concerned. Okay, so now let's talk about alcohol withdrawal syndrome. Has anybody had anybody in the ED come through with this? Have you? How did they act? Irate, hard to manage, right? Yeah, they are. They really are. So it happens when you suddenly stop the alcohol. Okay? Now, the onset can vary, and it will depend on how much they drink, the duration of it. You just have to know or look into their history. They may not be honest historians. The family may have to provide that. But if these patients are really dependent on alcohol, the side effects from this withdrawal are even worse. They just are. So you can't totally predict how it goes, but you have this stored in the back of your mind that they may go into this alcohol withdrawal syndrome. So I'm going to put that in the back of my head and be thinking it could happen. And if it does, it's going to start several hours after their last drink. They're going to start. And then it usually peaks 1 to 2 days, and then it will disappear if we manage it well. Now, if it gets to delirium state, then it's gotten much worse. So the ammonia levels are extremely high at this point, and the symptoms have lasted longer, and the patient has a greater reliance on alcohol. This is very serious when they get to this point, to delirium state. So let's just talk just a little bit about management of this. It's so sad. Here they are, critically ill, liver's failing, and they're going to have this happening. When it's just that syndrome, look at the minor symptoms you're going to see. Okay, and what were we going to use? We'll use benzos for them, yes, okay. We're going to have to give them thiamine. Remember, they are nutritionally not sound. They just are not. And so we'll give them thiamine. We want to prevent that Wernicke's encephalopathy with the thiamine. And multivitamins, so you give them the banana bag, you'll have an IV that's got that classic yellow coloring. We're giving them back these vitamins because they're nutritionally really poor. And then we'll just support them with other MAG. Might have to give them some glucose, whatever. You have to take this. It's hard on them when those patients are going through this. It's hard on the families when they're going through withdrawal. And it really is a challenge, not only with electrolyte management, but just their mental state too. Now, when they get delirium, it's really a big deal. Okay, they start having these bad hallucinations, and they can start seizing on you, and then you're really, really in trouble when this occurs. We continue with benzodiazepines. We will give them AEDs, anti-epileptic drugs, right? And we tend to prefer gabapentin or the valproic acid. One of those two is what we prefer when they get to this state. But then we have to start adding on Haldol, or we have to start adding on Thorazine for these patients. There's a CWA scale that you will use, just like you use other scales for assessing edema, whatever it is. You will do a CWA scale. And the reason you want to do that is quantify where they are, but also it will guide you on what medicines to give. And so it assesses these 7 different areas, and you'll have to do that in your charting. The tragedy, I guess it's tragic. How much time do you think in most ICUs you spend on charting today? 40%. That's a lot of time, isn't it? But it's what it is. It's just what it is. And so you will be answering these questions so you know where their CWA is. And then based on where their CWA score is, you'll give them benzodiazepines. So it's very, very important. Keep it calm. Use restraints if necessary to protect them, but statewide, right? And then it's got a lovely care plan on alcohol withdrawal in Lewis. Now, what does fulminant mean in Greek? What is the definition of fulminant in Greek? And you're like, I don't care. No, it means to be struck by lightning. Bam! Suddenly, these patients suddenly go into massive hepatic failure. It's just bam. It's not like we've been involving in what we've discussed the past hour and a half. These patients are on. This is where you typically see at university is acetaminophen overdoses. You can see it when we give them too much halothane. There's different things that can do it. That we're on. They are, wow, suddenly they are really sick. These patients don't do well. They have a high mortality rate. Anyways, so the first thing you see is a cognitive change. You'll get them through the ED. Either it's a drug overdose of those that are listed. It might be cryptogenic means, you know what, we know they're in fulminant liver failure, but we just don't know why. So you're going to hear that word, it's a cryptogenic issue. We just aren't at this point knowing what's occurring. And certainly your hepatitis can cause this too. It's very sad. So they still look like liver failure, but the onset is like struck by lightning. Suddenly we're on, and you see it in the ED, certainly at university hospitals since we're a level 1, right? Yeah, absolutely. So you'll see jaundice. They have big time coagulation issues. They glucose low, edema, etc. And they go into what? Renal failure mods. They are difficult to turn around when they get to this point. It's very sad. Very, very sad. Diagnostics, we've talked about what we talked about earlier, right? The main thing is that intake, saying it's a sudden onset. You're like, oh my God, they're in fulminant liver failure. That intake from the family is so important. They're in the ICU. These are critically ill. They have a high mortality rate of at least 40%. It's very high. So we're going to be having a swan in or oral vigileo where we're monitoring them hemodynamically, their fluid status. Absolutely. We'll watch their labs pristinely to see where we need to adjust. Electrolytes, very, very, very important. Minimal stimulation, keep them calm, keep it quiet, help the family through this time, right? Minimal benzodiazepines because they get what? Metabolized in the liver, and they are in what? Fulminant liver failures. It's not going to work. So we're going to have to be real careful if anything we might use. Librium, that would be it. And then we have to keep them safe with all of our patients, right? That renal status, you know what? So important to watch that. It honestly is. So often when the kidneys start failing, it's over, or we're not doing well. We're not managing them well at all, and that occurs. So just watch, their INOs. Watch for acute tubular necrosis. You learn about that from Dr. Richardson, which is intrarenal failure, right? So you want to watch that. It's a little bit, again, hard to analyze with liver failure patients. It's a different animal. So they're going to look at really the creatinine and the creatinine clearance differently. You're just going to have to trust them with the way they guide you in managing them. Watching INOs, daily weights are so important because they're third spacing, right? And that neurological status. These patients develop cerebral edema, and then we're really a mess when that happens because they can literally herniate. So if they tell you, I want those neurochecks, and I want you watching those ICPs and that CPP, and this is where I need it to be, and you're not able to manage that, you gotta let them go. You have to keep them informed of the challenges you're having with maintaining these parameters they're giving you. They're a run for your money when you get to this point. They really are. And of course, they have seizures. Yeah. Well, if we can even get them a transplant, right? Yeah. That would be a blessing, right? Yeah. But often they're so critically ill. Really, at least a 40% mortality rate. They never make it to that. And if it's alcohol-induced, often they're going to exclude them, right? They may not. The case study you're going to do, the patient I took care of, he struggled with alcohol abuse. Okay, all right, we're doing really good. What do you think? Are we okay? Are we kind of gliding through it all right? Not too bad? Does it make sense? We're just building it. Yeah, you can do this. You got it. And they're really an honor to take care of. I just love taking care of these patients. I mean that, and their families. It was hard on them, right? let's talk about liver transplantation. You're going to do a case study for me. It will open today at 4, and it's actually that patient I've been talking to you about, and I took care of him over several weeks. And I got to even go into his surgery for his liver transplant. Some things I had to change to protect him. He's younger than my story shows in what you're going to read about him, but the labs and all are his life, right? Yes. Okay. So, liver donation. Hey, guess what about University Hospital? We are number 2 in the United States for living donation. Number 2 in the U.S. Is that incredible? We have the best hepatology team in the United States right there at University Hospital. They are awesome. They are. They came to us from UCLA. Dr. Poordad did a lot of original research. We have them from Cleveland Clinic. Why do you think they're here in South Texas? We're number 1 with liver failure in the country. It's us, right? So if it's from what? Diabetes, obesity, metabolic syndrome. You see what we do. We have problems with that in South Texas. Horrible problems, right? Yes, we do. But they are here doing exquisite research, and so we are just top-notch. It's just incredible team. So we can do a living donor. I could donate a part of my liver and give to another person who's in need. Their liver has folded, right? And I can do a living donor donation to them. Now, it will take my liver to regenerate, and for them, the recipient of getting my left lobe, it might take them anywhere from 5, 6 to 8 weeks for it to regenerate to its normal size. That's what it takes. That's not so bad, is it? Yeah. And it works great when we can do this. It's really nice. We love doing them. There's a shortage of cadaveric livers, so living donation is the way to go. And we're number 2 at University Hospital in the United States. And our surgeon that does this is just way cool. He's just awesome. It's a really exciting team to work for. Cadaveric, of course, they're deceased. And sometimes with a cadaver, we'll give a left lobe to one person, right lobe to another. Certainly we do that. And then we have deceased cardiac donation. You don't see that much at the private hospitals in the city, but certainly we do them at University Hospital. So, and if you ever take care of a patient that is having this done at university, you need to ask, can I go through this process and watch it unfold? Because it's quite interesting. So in this situation, we know that this patient, there's just no turning around, that this patient is dying from whatever the reason is. They are in massive heart failure. We can't turn this situation around. So we ask the patient's family, can we harvest their healthy organs? And if they say yes, we take them into the OR and we allow the family to be there if they want to. We take them off all their pressors. We let the patient die. As soon as they are pronounced dead, we start retrieving the organs, okay? Yeah. And then transplanting, okay? So the little case study you're going to have, actually, he was to receive his initial, to receive a DCD, but the patient didn't die soon enough after they extubated him for the liver to be retrievable. So then he went back on the list and he ended up getting a cadaver. It's interesting. So you'll be doing that case study. I know him well. And I loved taking care of him. Very young, younger than it states, to kind of protect his identity, yes. So deceased cardiac donation, we just take them in the OR, we take them off all vasopressors, everything, we let them die, and we start retrieving organs, okay? Alrighty, now, here we go. Eligibility criteria varies in the United States. Some organ transplant centers will say, they have to totally be abstaining from alcohol usage for 6 months before we're going to give them a liver. You know what? The case study you're going to have, I altered it so you wouldn't know who this person was, but sometimes we'll give them an organ, okay? Even if they haven't been abstaining for 6 months. It just kind of, we're going to work with them. It's not a total, you haven't done the right things, so guess what? You're not going to get it. Our team here looks at things differently. It's a wonderful team to work with. All right. So we'll look at, if they have really bad cardiac respiratory disease, we know that giving them a liver that there's very few of is not going to work, right? That would be wasting a valuable organ. That probably isn't going to turn this situation around. And certainly if we have these metastatic malignant liver cancers, HCCs, you know, we can't give them that liver transplant. Informed consent, you know about that. It's an extensive evaluation. Absolutely. When you come to that case study, you'll see the patient, you're going to see his labs, you're going to see his presentation. And you know, you might want to use these slides when you're answering those questions, okay? So we evaluate them psychologically. Financially, this is a lot of money to go through a liver transplant and the medicines required, everything afterwards, the care. Do they have a strong social support system? Because they're going to need that. And are they going to be compliant? You know, if they're not, then it's wasting a valuable organ. And we don't have that many, right? And it requires a lot of education. Post-transplant, so we do them a lot on the 9th floor at University Hospital. In our cardiothoracic unit, we do liver transplantation there. They're in the ICU. You've got to watch it. The case study you will go through, it actually happened. It's all true. What happened to him a few hours after he received his transplant. So it's your eyes, your monitoring of their vital signs, of watching, not just writing it down, putting it in the EMR, but it's like, okay, analyzing this, watching them when you do their assessments, thinking, wait a minute here, I'm not comfortable with this. You are the one that's responsible for that, right? So you monitor them pristinely with their neurostatus, trending, their vital signs, everything listed here. Watching for signs of infection. You know that can happen. It's not as common with the liver. They usually do very well with liver transplants. Yeah. Watching for clotting problems. Absolutely. Watching that INR, that PTT. Monitoring drain output, and that became very important with this case scenario you're going to look at. Looking at those drains, the amount of output. Wait a minute here. This is interesting. This should not have that biocolor drain. It should not have this coloration. You call that provider. There is a problem there. There must be a bile leak occurring, right? Watching for acute kidney injury that Dr. Richardson so clearly taught you about. You are the one that's doing this. Yes, you're the nurse, but you're smart. You have to do this. They'll be on immunosuppressants. They're going to be on antibacterial agents and anti-inflammatories, absolutely. And we'll do blood cultures when necessary. Okay. Watch for post-transplant. Oh, what time is it? So guess what? I want you to look over this, okay? I want you, it's nice reading. Your book is fine on it. I prompted you there what to do, okay? As far as what to read for the case study, you'll do just fine. If you have questions, you can let me know, okay? And these case studies in the book, the e-book, but also the case studies, a lot of times you'll do in a post-conference, they're really helpful. They'll challenge how much can you assimilate this information. It's great stuff, right? Questions about liver. You okay with it? They're wonderful patients. I love caring for them. I really, really do. We're only going to take a 5-minute little break so we can wrap it up with pancreatitis. Okay? I promise you we'll make it just about on time, maybe 5 minutes over. So what time do you have right now? 10 after? Give me a minute. Now, on the liver case study, you can take it as many times as you need to until the deadline, right? You can take it over and over, right? It will help you understand things better. Well, first off, I appreciate you letting me go over time a bit. We'll wrap it up. But let's start about talking right now on acute pancreatitis. How many of you had patients with pancreatitis? Yeah, yes,
I'm
yes.
gonna leave it for.
How about acute pancreatitis in the ICU setting so far here in your rotation clinically? Has anybody had anybody in the ICU with acute pancreatitis? Yeah. Yeah, it's really sad. I think one of the first ones I took here was when I was active duty Army. And so one of our surgeons, her husband developed a leukemia, and he ended up from the chemotherapy agents going into acute pancreatitis, and so we had him in our unit. And he was in his 20s, I think he was like 28. We ended up losing him, but acute pancreatitis, don't mess, you don't want to mess with these patients. I mean, they are very critically ill. They sure are. So we'll just look at, there are many things that can cause it. In women, we see it with gallbladder issues. Unfortunately, with chronic alcohol abuse, we see it more with men. So again, we see this up to 81 a lot. We see it at university a lot. Has anyone had anybody in the ICU with acute pancreatitis this semester yet? Certainly the people at university probably have seen this, I would think. All right, anyways, that's usually my clinical site, but since I'm retiring in December, I got a little break, but I missed it. I love it. This is so exciting to see all these things unfold. Like, wow. So anyways, less common causes, let's just look at them. Certainly drug reactions can cause this. Pancreatic cancer, when we can have lipid issues. You can just see this, biliary sludge we often see when patients have, when they get septic shock, they can have this occur. But you see there's a lot of different things that can lead to acute pancreatitis. I can literally induce it too with an ERCP being iatrogenically just from us doing that procedure. So I would always think, geez, if I had a patient I'm on a med surg for and they have an ERCP, I better be watching for acute pancreatitis to develop, right? So this is how we look at this trauma. Absolutely. What you'll see is like if, with children, they can even develop this, but let's say you have somebody who comes into the ED at university and they were on a motorcycle and they got thrown off of it, or they hit the bars and they were thrown off that motorcycle. Just that impact, that physical impact on the pancreas, they can go into acute pancreatitis from that alone. Yeah, so you're always thinking, right? That's what you should be doing. Just a cut to the chase thing in acute pancreatitis. Now you can have chronic. How many have seen chronic in adult one? No? Interesting, okay. Well, you're going to see it. I mean, a lot of it in this city is unfortunately alcohol use, excessive alcohol use. But what happens when we go into pancreatitis is this acute inflammatory process that occurs because we have a premature activation of those enzymes. That's what happens. We'll talk about that in a minute. Remember, those enzymes are there to what? Break down carbohydrates, fats, and proteins. But when they're prematurely liberated in the pancreas, they start literally auto-digesting the pancreas itself. And it's very painful. Pancreatitis, acute pancreatitis is very, very painful. So you just start destroying the pancreas and anything surrounding it. So we'll look at a little picture here that I'll convince you of. So just as a tiny little review, it's accessory, it's elongated, fish-shaped, grade, where it's located in the curve of the duodenum, behind the stomach, whatever. But here's something real important. It has a loose connective tissue covering. Okay, so I didn't have time, but they would let me have a pillow from downstairs. And so if you did an autopsy on, or you get to go to surgery and you're looking at the pancreas, truly it looks like this. It's a little bit too big, but it doesn't have that tight connective tissue coating like the Glisson's capsule on the liver. It looks like a blob of pillow stuffing. So can you imagine if I have premature activation of those exogenous enzymes that are going to break down carbohydrates, proteins, and fat, and I don't have a tight connective tissue covering even a healthy pancreas? Can you see how when it starts getting prematurely activated and it gets liberated, and we'll see in a minute where it's located, the daggum destruction, auto-destruction that it starts causing. This is truly what it is. All it is. Where did I leave the little? Yeah. It is, and it's nasty. You'll have a run for your money when you're taking care of these patients. Yeah, they're really sad to take care of, especially with alcohol, because they already have problems with abuse of alcohol, and then you add on all this stuff here. Okay, just to show you, prematurely, it's just a blob of like stuffing from a pillow. There's not that connective tissue. And you can imagine everything that's surrounding it, how it starts auto-digesting your intestines, everything around all the tissue. These patients get septic and go hypovolemic in a second. They, at hour 48, go into hypovolemic shock. Okay? So they are interesting to care for, too. They just are. I know the heart's cool. I get it. And I like it. I do. I've studied it a lot, and I respect it. But yeah, it's kind of, I think we're getting more predictable at it. Not these organs, not liver, not this. You're really in for a run to take care of these patients. Not to worry about the structural features, but as you can imagine, if I start having edema here at the head, it could do what? Occlude that common bile duct, right? Here's the right and left. Hepatic duct is common, hepatic duct, storing it here, the bile here, and you start pressing on that, you're going to have what? They also can go into liver failure too. So you've got to watch these patients. They're critically ill at this point. Very hard to manage, yeah, but interesting too. I won't go over this other than it's just a reminder: main pancreatic duct, common bile duct, the ampulla of beta where they join, and then the sphincter of Oddi. You just have to know this stuff because it starts making sense why they're so daggum sick and why you've got to really fight hard for them. Okay. I think you understand all this. That, we have glucagon made, there are insulin made, there are somatostatin, and you know what? It's just a real balance between insulin and glucagon in your body. And then the liver, of course, is directly involved in all of this too. So it's a real intricate balance between this. The center cells. So we're going to move on. Really, I don't need to go over this. It's fine. But the pancreatic enzymes, exogenous, being trypsin, amylase, and lipase, that's where this auto-destruction starts occurring. They start literally eating up the dadgum pancreas and causing all this horrible stuff to start happening. So I have to slow that process down. I have to stop it, and you'll see how we do that. I'm just showing you here, remember I was showing you with what proteins, fats, and carbohydrates, that if they get prematurely activated, what do? Abnormal blood clotting, edema, they bleed, they cause necrotic problems. Elastase, they break down elastic tissues, so the blood vessel walls break, they bleed. Amylase, well that's interesting. Carbohydrates, there's nothing that happens. So do you think we're going to have them on a carbohydrate TPN-based IV solution? Yeah, because the carbohydrates don't bother this situation. It's the proteins and the fats that do. Okay? Yeah, phospholipase A, the lipids, it just breaks down cell wall membranes, causes fat necrosis. They start literally having pulmonary complications. So this alone shows you how hard they are to manage. They really, really are. Okay. And then the problem here is trypsinogens in an activated gut. It becomes activated within the pancreas with these patients. So autodigestion occurs. This is no need. But just to remind you about secretin, what happens with the bicarb release. It just promotes bicarb release. Remember, the pancreas does what? It releases upwards to several liters a day of bicarb to keep you, and you've got that in your ABG lecture, right, to prevent you from being acidotic. And then your cholecystocyanase kinase. So you can have degrees of acute pancreatitis. You really, really can. And you'll know about that when you read their chart. And y'all go to class, to clinical, and hear a handoff and you go and assess the patient. Then you start looking at the chart and seeing what are the providers writing, what's going on, is it mild, is it a severe case. The problem is that these have that ability to just destroy all these structures, and they're being prematurely liberated in all the surrounding organs around that pancreas. You can imagine the destruction that occurs. It's pretty bad. I'll let you read this. It's just a synopsis of the pathophysiology that literally, but it's autodigestion that occurs to anything surrounding it. It's autodigestion. So literally they start losing fluid and they go into low pressures, hypovolemic shock, and they get septic, okay? This is your challenge in taking care of these patients. If I have low volume, I start doing what? Organs fail, the sepsis issue, organ failure. You've had both of that content already. This is a lovely lecture to have after acute kidney injury. It is, because you're going to see that in these patients, acute kidney injury. That's from your textbook, just look at it. But how do they present? So I'm in the ED. So they are going to have this left upper quadrant pain. I show you here and superimposed here in red where the pancreas is. So they have that left upper quadrant pain. They might have some epigastric discomfort, or it may radiate to the back. You're like, well, who cares? But you're getting them in the ED. And the doctor's not always going to be there with you. Not at all. And you're going to have to think, oh my gosh, listen, this is deep, severe. He's saying it's a sudden onset, maybe when they had an alcohol binge, you know, and when they vomit, they don't feel better. You're like, dadgummit, I got to call a provider. At university, they're right there for you. Not maybe as rich a response than some of your other hospitals, but they're on, okay? And when they lie flat, that's when the pain really gets bad. They want to curl up on their side, or they want to sit up because their blood pressure allows it. But lying flat is very uncomfortable for these patients, and you're thinking, oh my God, I know the mechanism of injury, what occurs, or I know they have chronic alcohol abuse. I get what's going on, okay? Abdominal distension and tenderness, yes, they're guarded. And again, unfortunately, if it's due to alcoholism, they will have weight loss. So now you might see no bowel sounds. They may have a paralytic ileus, low-grade fever or inflammation. If it's also impacting the liver, they get jaundice. And again, this hypovolemia starts, and often you'll see that if you get them through the ED into the ICU, you better watch in that 48 hours. They love to go into hypovolemic shock. They third space on you and drop their pressure and get real tachycardic. So you want to always, this pathophysiology is really cool. I mean, but the beautiful thing about it is when I'm caring for these patients, I'm resonating on that to be thinking ahead to protect my patient. I'm there for them, right? Absolutely. Yeah. Now, other rare findings, though, you're going to see are these Gray Turner, they like this on that CME, or the Cullen sign. So let's look at this and see what happens. You already had your online lecture on disseminated intravascular coagulation. So like I told you, this is it's a great, have you had the septic shock lecture yet on sepsis? Or? No, well, they'll talk about this then. I thought that you already had that. Okay, so they'll get this discoloration around their umbilicus. That's called the Cullen sign, and that's ominous. You also, I would think that they talked about this too with a ruptured abdominal aneurysm. You can see this coloration sign with them also. So you're having to extrapolate. What is it? You know, is this acute pancreatitis? Does this patient have an abdominal aneurysm? And you're literally thinking, and that's why you came into this profession, because you love people, you want to help them, but you like thinking. You want to be there to help people, right? Absolutely. It's not just information for information. We're there to help patients. Bottom line, we really are. Okay, so you're the nurse, you're looking at the record, the patient has pancreatitis. There you see this bruising around the umbilicus. Which of the following is an appropriate action for that patient to take? You've read, you're looking, and you see in the chart, or you heard the change of shift saying they have a positive colon sign and they have acute pancreatitis, you would do what? Remember, colon is what? Look around the umbilicus. They literally, through the acute pancreatitis, I'm starting to what? Degrade the blood vessels. I'm literally, it's almost like an X-file thing. These premature activations of these enzymes slowly start chewing up things. It's terrible. These are bad to take care of. Or you could get a Grain-Turner sign. Again, it can happen with what? An abdominal, ruptured abdominal aneurysm. Or it can happen with acute pancreatitis. Watch for these signs. You get them in through the ED and you start seeing this, and you know they have problems with alcoholism, and you're like, uh-oh, I get what's going on. You may not have the luxury of getting them at what? University Hospital, which is a level 1, or BAMC, which is the only level 1 trauma hospital in the military. It's BAMC. It's the only level 1 in the world. Can you believe it? That place rocks. I practiced there and was on active duty there for many years, so I know Colonel Ford and Lieutenant Colonel Cleveland very well. We are colleagues. Labs. So let's look at their amylase. We'll start trending that and their lipase levels. We have to watch that, and we're going to look at glucose. Now, calcium. That's one that's very important to watch with these patients, because what happens when we start having this autodigestion to occur, there's a saponification, a trapping of those free fatty acids that occur, and so it leads to these areas of fat necrosis, and they drop their calcium. They drop their calcium level. So that's not good when that occurs, when that happens with these patients, not at all. And we'll look at what kind of signs and symptoms would you see, maybe even before you get that calcium level back. But if you have a patient who comes in with acute pancreatitis, a BMP, a Chem 7 is not enough. You need to get what? You need to get a Chem 10, a calcium, phos, and NAD on these patients. Absolutely. So these signs and symptoms, they come through the ED, they're critically ill, and they're saying, oh, I have this tingling around my lips, you know. Okay. And then you go ahead and you analyze them, you know that they maybe have a history of alcohol abuse, okay. And you do a Chabosic, and they love this stuff, what, on boards. You could get them at an outlying hospital and have them air back into us at University or BAMC, right? And so with a Chabosic, what would I do? What is it telling you? To tap over that facial nerve, and they twitch. And it will tell me I have a low calcium level. You can literally do that. You would do that in the ED. I would do that, okay? It's a sign that this patient has a low calcium, and we certainly don't want them to go into tetany, right? What about a positive Trousseau sign? I'm gonna, in this lecture, there's some little YouTubes you can watch, and I want you to watch them. But literally, with a positive Trousseau sign, when you blow that blood pressure manual cuff up, they'll literally start clawing like this. The hand just claws. That calcium level is dangerously low. Absolutely. And if it's too low, they'll develop what? Tetany. So there you see. So here you see Chabosic above in A and Trousseau below. And you will be doing that in the ED, absolutely. Very easy to check that. And if you're in an outlying hospital, just do this. Help the diagnostician, help that provider to make good, confident choices in caring for that patient. Of course, they'll have elevated liver enzymes. It's an inflammatory response, and you'll see this occur too. And typically, you'll see platelets will drop. We can do an EGD. We talked about that already in liver, so I won't repeat that. But you will be sure and know when they're done what to watch for and what can happen. We can do an upper GI series. CT, contrast enhanced CAT scan is really the gold standard, or even ultrasonography. The problem with contrast enhanced CAT scan is I'm giving them what? A dye. And if they're already having a low blood pressure and there's third spacing, and now I'm giving them a dye, I can put them into what? Acute kidney injury. Maybe they're already in it because they don't have an effective circulating volume, and then I add insult to injury. So if they want this, you have to really be watching for that patient and being an advocate and asking the providers is really what you want to do, right? Yeah, you're smart, you can do it. So I'm completing an assessment. I know they have acute pancreatitis. What finding would be first to report to them? Cholecystitis, albumin's elevated. They have severe pain. It is painful. But what about that hand spasm? What about that trousseau sign? Now remember, it's priority. That you've got to get their attention on and immediately let them know about that before you get that calcium level back. There's a lot of complications that can occur with these patients. They're a run for your money. They honestly are. When they're this ill and they're in the ICU, you will be very busy. They may be your only patient. They're very hard to take care of, and I've taken care of many of them. But I could have a pseudocyst, and that's just the enzymes that's encapsulated. You know, they can. The problem with these pseudocysts is they can rupture and then put them in peritonitis, and then I'm into even worse trouble when that occurs. They can have abscesses that can perforate, and so often with these patients, they will go in for a lap every other day to wash them out. They'll just literally wash them out with tons of liters of fluid, 15 liters, just to get rid of this tremendous amount of pus that's accumulated from the pancreatitis. Yeah, it's just nasty. I've seen it. It's terrible to watch how much pus can accumulate. If it gets really, really bad, we can go into necrotizing pancreatitis, and as you can imagine, I've just overlaid it in red. It will start blood eating into it. It can perforate your bowel. It can perforate the diaphragm. It can literally, these exogenous enzymes get prematurely activated, and they love to just walk. It's kind of like an X-file, I think of this as. They can literally go through the diaphragm into the lungs, and then I'm on with lung issues. So they're not easy to care for. You are very important in caring for these patients, guys. Your eyes and your thinking will keep things going in the right direction. If you have questions, you're not sure about something, you ask somebody. You ask a nurse that's been around the block longer that can be there to help you. So they can have pulmonary involvement. You've learned all about ARDS and what happens with that, and they certainly easily go into ARDS. They are intubated at this point, of course. We've already talked about them dropping their calcium levels so tetany can occur. We would hope to catch it sooner than that. The peritonitis, it literally is like an X-file. It likes to perforate organs, and then they get septic on you. Acute kidney injury, they're third-spacing fluids, so they initially go into what? Pre-renal. They don't have an effective circulating volume. If I don't catch it soon enough, then I go into intrarenal, which damages the kidney, right? They start throwing thrombi. They start throwing emboli. And then that DIC presentation occurs with just massive clotting. And then just from the massive third spacing, they can develop abdominal compartment syndrome. They are a challenge to take care of. It doesn't sound like it. I know we always think, all right, neuro, or all right, heart. And that's great. I have great respect for both. But these liver and pancreatitis, they're really a run for your money, taking care of them. It's a challenge. So what are we going to do? We're a team. We're going to work together to help them. They have severe pain. The pain is horrible. So we've got to do that, and we've got to medicate them without dropping the pressure. So we've got to support them with vasoconstrictors along with volume of fluid. Because we also don't want shock, right? We're third spacing. We're going to do everything possible to keep those exogenous enzymes from being released. Put them on an NG2 to low wall suction. Keep them in PO. They're on TP. They are on TPN. Yes. Watch for signs of infection. They can have peritonitis. They can get septic in a second or on you. And then just whatever caused this problem, which we talked about initially, get rid of it. Just get it open, address it, so that it doesn't keep causing them to have these terrible sequelae going on. anybody who's critically ill needs nutrition to heal, right? So we'll have TPN management for them. They are, even though they're lying there, they're sedated and all, they are really in a state of needing a high nutritional intake to make it through this terrible problem. These patients are critically ill, guys. I know the heart gets a lot of attention, and I love the heart. I studied it extensively, and I have great respect for it. But these patients they're very complicated to take care of. They really are. Okay, so the pain, you know about pain management. We want to take care of that. But we'll also watch to be sure any side effects of dropping their pressure too much. We're going to have to communicate with the provider very well, saying to get them sedated and pain-free. This is what I'm having to do, but they're dropping their pressure, so they might increase crystalloids, infusion. They may tighten up on a vasopressor like norepinephrine. Rating the pain. Now, positioning, these patients don't like to lay flat, and because the pain is excessive when they're lying flat and supine. If they want to kind of curl up in a fetal position, or when you first get them in the ED, if they can even manage it with their blood pressure, they want to sit upright. That prevents this massive inflammation that's occurring to cause that pain. So you want to facilitate positioning them to where they're comfortable and explain to them. Don't let them think what's wrong with them. Here they don't feel good. Maybe it was caused by alcohol and they're already feeling bad about that. You want to just help them. Say, I'm here to help you. Let's try this position. And then just reassure them that you're right there with them, right there with them. And even after, if they have to be intubated, talking with them, even if they're sedated, continue to talk with them. The last sense to go is what you're hearing. Continue to reassure them that you're there for them. We're working hard to help you. Your family is here. They know what's going on. That's real important. Just general comfort measures because they feel crappy. They feel really bad. We have to keep them in PO. We have to suppress these exogenous enzymes from being released because that's the genesis of acute pancreatitis. It's autodigestion. It's like an X-file. It's literally just chewing up any tissue it can. Vomiting, they'll have an NG2 cam. We can give them H2 blockers. We prefer proton pump inhibitors. That's our preference. And omeprazole is a common one that we use. Okay. Pain, oh God. If they can even convey it to you, they're in a lot of pain. So we might give them some Bentiol as an antispasmodic. Certainly the morphine, as I've talked about. We might give them Diamox. You've probably heard about that in the ADG lecture. But anyways, what that does is it decreases the bicarb production. And so that is what to decrease these enzymes from being released. Okay, ineffective tissue perfusion. That's what these patients in the ICU setting. It absolutely is. They just vasodilate, they drop their pressure on you, their temps are high, they're septic. That's truly what you're going to see is a sepsis profile. And so with sepsis, it's just what? Support them with vasoconstrictors, fluids, right? Absolutely. Keep them comfortable as much as you can and trending and informing that doctor what is going on. NPO, of course. NG, watch their electrolytes, trend them. It's all about trending. In your clinical setting, your professor's going to come around and say, let's talk about their labs. Tell me about, let's trend them. Tell me what they were on night shift, and let's see what direction are we going in. Is everything we're doing hitting a home run? Are we going in the right direction? And you're like, Rise, I'm not the physician, but you are a very important person. You're there, your eyes are on these patients 24/7. You have a very keen knowledge about your patients and how they're responding to what we're doing, right? We have to keep them in PO. Yeah, we have to. We don't want to do anything to stimulate the exogenous enzymes from being liberated and causing more problems. Since they third space, from Dr. Richardson's lecture, we have to watch for AKI. So you're globally looking at them in many perspectives and analyzing your labs and seeing how they're responding to fluid boluses. Very, very important. And it's exciting to take care of these patients. we've already talked about the signs that occur with the low calcium. Watch for those. Okay, just watch for those signs. At its worst, they might start having laryngospasm. Usually at this point they're intubated, so you won't see that, but you could see seizure and tetany if that calcium gets that low. It's a very late sign, so you've got to watch that and keep the providers informed. Yeah, you're going to give them calcium back. Absolutely, you will. Gluconate, you give a lot. They can eat, of course. If we feed them enterally, we've got to bypass what? The duodenum. If I feed them in the duodenum or in the stomach, then I'm going to activate what? Those exogenous enzymes, and we will make this situation even worse. So we'll probably put a jejunostomy tube in and give them enteral feeds there, because we don't want to stimulate these exogenous enzymes. They're really interesting to care for. If it's alcohol-induced, you're having a lot of problems with family dynamics, with their life coping abilities, their problems with life, and then we get into this state where they're critically ill. So it's an honor to take care of them, but it's a challenge. Okay, TPN, you can do that. Enteral feeds are nice if they can manage it, but again, jejunum. High carbos doesn't cause a problem with exogenous enzymes, but they need proteins also. We just have to watch them. Yeah. So the interesting thing, as you can see here under impaired gas exchange, all of these nursing diagnoses are so important, y'all. You may think it's just something you're going to do as a student. They really frame your thinking and your caring for these patients. They honestly do. I would think in the future, do doctors even know when you say, well, there's altered tissue perfusion as evidenced by, no, that doesn't equate. So I think one day we're going to have a merger in our dialogue in a different way of nursing diagnosis, because it just doesn't translate if you talk in that verbiage to providers. That's one problem about it. It does frame your thinking, though. Okay, so we have an issue here where the gas exchange is very interesting, and you probably have this in patho, where we have decreased surfactant production, which causes the alveoli to collapse. We have fluid accumulating retroperitoneally, because that's where the ovaries and the pancreas are all retroperitoneal, so they're hidden. And so sometimes you don't see how bad things are until it's really bad because of their retroperitoneal location. But anyways, they'll be intubated, and we want to be sure and assess those breath sounds, trend the SATs, see how they're doing, how are they managed, watching the ventilator settings and see, is ARDS starting to occur? Is there a resistance to the tidal volume you're getting? Are your peak airway pressures going up? Those things you already learned about in pulmonary. That's why this is positioned nicely after pulmonary. Distension, yes. So pulmonary issues, watching them, checking breath sounds, checking their accommodation with the ventilator, doing intakes and outputs. Are they going into acute renal failure, acute renal kidney injury? Position them, turn them. They're really uncomfortable. And they've got to have pain management. This is really painful. Pancreatitis is like having an internal fire. It's really painful. They need your help in preventing the pain, because that's going to make everything worse. You're very important to all these patients, y'all. You count. Now, here's the thing. If all this is caused by alcohol, they could go into what? ETs. Absolutely. So then you've got that problem on top of this, and then you have to use your benzos, like we talked about in the liver. Sometimes we'll use clonidine. That may help with these patients with their responses, their high tachycardia, and their restraints. Be careful. Just be sure you're explaining to the patient why, and you're documenting every 2 hours. They get septic easily. Of course they do. They're third spacing, they have all this sludge, they're eating up tissue. Yes, they get septic. So we will watch for all of this and be sure that we're doing good hand hygiene and following everything, just trending them, assessing them, and letting your providers know. And watch for your trough, like when you have them on antibiotics, which they will require. You know what? If you even pull them through this, which we're getting much better at managing this, but sometimes we don't. So recently, in our city, we lost a known individual from acute pancreatitis, and they were very young, and so it's a hard one to handle. It is, and sometimes they feel terrible because it's alcohol-induced. And so just helping them, if you can even get them out of this state, which would be a blessing, okay? So what would you do? Are you going to watch for signs of low calcium? Of course you will. You have saponification of your fats, which lowers what? Yeah, the calcium level. Would you monitor for infection? Well, you better. Really? Yes, absolutely. Would you give them high diet in protein and fat? You need protein to heal, but what about the fat? No. Would you restrict fluid administration? Well, watch that, but for sure, you better watch for signs of low calcium and for signs of infection, right? You would not restrict fluid administration. They need fluids like crazy. They're third spacing. They're dropping their pressures. Their MAPs are in the toilet. Would you see right upper quadrant pain? No, I don't. Left, right? Would you see pain that's worse when they're sitting up? No, it's better when they're sitting up, when they're on their side curled in a fetal position. Would you see severe mid-epigastric or left? Yeah. Would there be pain relief with defecation? No. No. All right. Oh my gosh, you kids have been so sweet. Do you have any questions? Does this make sense? I think.